All right. Hello, guys. I'm muted. Can you guys all hear me? Can you put up in Slack if you can hear me, guys? All right. Hello, guys. I'm muted. Can you guys all hear me? Is someone put their mic open and playing the YouTube video because it's echoing?
I don't think so.
No, I don't think so.
I think it might just be your mic. But it looks like everyone can hear us on Slack, so that's good.
All right, brilliant. All right, so welcome, guys. Today on to Gynae, OBS, and Sprogs. So we are going to be going through a case study from going from our later teens to motherhood and twins as well. So this is looking at the general timetable for today. We've got today starting off with fantastic Dr. Tolu, who will be talking about period pains and the wonders that brings there. We've got Bronwyn Woodburn, who is going to be talking about multiple pregnancies and all the fascinating issues there. And then we've got Yellow Babies from Dr. Chloe Smith, and she'll be talking about how do we get yellow babies. And then we have me talking about pediatric respiratory diseases and the COVID crisis and how you should, when and where you should be worried about them. And then we have a special guest. She's not here yet, but she will be here later in the afternoon, Dr. Emma Herons, and hopefully we'll have a brilliant speech by her. So I'll take it off with Dr. Tolu.
Thank you. I just need to start sharing my screen. Intasar, do you mind stopping the screen share so I can start sharing the screen? Thank you. Hello, everyone. I hope you can hear me fine. So I'm going to be taking the first section of the Gynae, OBS, and Sprogs webinar today, the virtual clinical placement. For those of you who aren't on the Slack channel yet, if you don't mind scanning the QR code, that will take you to the general channel, and there'll be a link there to take you to our specific discussion channel, which will be quite active today. Can everyone hear me okay as well? I'm looking out at the Slack channel. And everybody can hear me? Okay, I'm gonna take that as a yes. No one said anything, so I'm gonna take that as yes. Fantastic. So taking you through today, we're gonna discuss a case. First of all, we have Mariam. She's 24 years old. She works in retail, and she's got painful periods. What questions would you want to ask from Mariam to find out a bit more about what's going on? Oh, thanks guys. If you can put in the Slack channel, so every time you see this Slack logo, please throw your responses, your ideas in the Slack channel. I'll just give you a minute or so to think about what you want to ask. Yep, so someone said, how long are her periods? Someone's asked, are you pregnant? When did they start? What pattern do they follow? How heavy are they? Someone else has spoken about heavy bleeding. Perfect. Are they regular? Perfect. These are all the sort of things that you'd expect to ask as well. Any signs of excess bleeding? Perfect. Thank you very much. So someone has said, has she always had painful periods, or is this new? Has she tried anything already? Does she have the IUD? So these are all really important questions you'd want to ask. So moving on, you've asked all your questions. She tells you that yes, she's always had painful periods, but they've worsened over the past 3 years or so, and that the pain usually starts 2 days before her period and ends with her period as well. And she describes the pain as a sort of electric shock type pain, and quite a graphic image of, shards of glass in my tummy, especially when I open my bowels as well. She describes as having a normal flow, and she describes the pain as being worse during sex. She has a pain worse during sex all the time, but it gets even worse around the time of her period. And she's tried ibuprofen and paracetamol, but it doesn't really work. She can't get to the cause of the pain. So again, in the Slack channel, as you've all done before, what would you think is Mariam's diagnosis? Again, I'll give you a minute to have a think about it, and you can put your suggestions in the channel. Okay, someone said, oh, okay, people are asking, or people are saying endometriosis. Fantastic, bang on, it's endometriosis. So for the rest of this 40 minutes, maybe 45 too, we're going to understand what endometriosis is, recognize why endometriosis causes dysmenorrhea, that's period pain, recognize endometriosis in a patient history, as many of you have done fantastically already, identify biological and psychological impacts of endometriosis, and we're also going to look at some of the treatment options we have available. So just doing a bit of background, a bit of a recap, because a lot's been going on. This is a picture of a womb, just to orientate you as well. These are the fallopian tubes here and here. And also you'd have your ovaries on the end here. And we have the cervix, the uterine cavity, and the fundus of the uterus too. So the layers of the uterus are as follows. We have the endometrium, that's the inner layer of the uterus. This is the layer that sheds on a monthly basis as well. We have the myometrium, remember myocytes, muscle, that's the muscular layer. That's the layer as well that contracts, causing sort of the period cramps that people experience. It's also the layer that goes in overdrive during labor as well. And we have perimetrium, so the outermost layer as well. Think of perinephric fat, that's the layer that surrounds the kidney, peri is around. And like I mentioned before, it's the endometrial layer that sheds. So endometriosis is defined as the presence of endometrial-like tissue outside the uterus, which induces a chronic inflammatory reaction. Breaking that down a bit more, we have this tissue, this sort of endometrial tissue. This endometrial-like tissue, it responds to the cyclical hormonal changes. And remember that in endometriosis, this is outside the womb, so in different areas in the pelvis. So when someone is having her period as well, she's also bleeding outside of the womb, which is part of the reason why she gets pain and can lead to infertility as well. But we'll dig deeper into that in just a moment. It affects about 10% of women, and the common sites that you find in endometriosis, the ovaries, the uterosacral ligament, so that's one of the ligaments that help hold the uterus in place. Uterus to sacrum helps hold that in place there. The pouch of Douglas, that's also known as the recto-uterine pouch. So this area, this space behind the uterus, and the broad ligament, that's essentially a flat sheet of peritoneum as well. It also can be found in the nose, in the nasal septum, in the lung, and in the central nervous system as well. So even though these cases are quite rare, they do exist. So someone might have a hemothorax, that's it, a small hemothorax as well, or may have nosebleeds on their periods. Now we're going to look at the etiology. And oftentimes in medicine, etiology is taught in the earlier years, but later on, when you're on the ward, sometimes it gets forgotten. But it can be quite helpful in trying to understand how a disease process or how a condition comes about. So one of the theories in which endometriosis occurs is through retrograde menstruation, where essentially the menstrual blood containing the endometrial cells flows back instead of out of the body and through the cervix, through the vagina and out of the body. It can flow backwards through the fallopian tubes into the pelvic cavity. And therefore these endometrial cells then stick to the pelvic walls and then grow with every menstrual cycle that occurs. Now, whilst this makes sense on the surface, it doesn't necessarily explain how do you actually get these endometrial deposits in the nose or in the lungs. So it works on the whole, but there are some flaws in this. Another theory is the transformation of peritoneal cells, also known as induction theory, where essentially it's thought that hormones or immune factors promote the transformation of peritoneal cells, the cells that line the peritoneum, into endometrial-like cells as well. Another theory is hematological lymphatic spread. So the endometrial cells somehow enter the blood vessels and the tissue fluid vessels as well, and are spread across the body. And again, this might explain the distant deposits, but we're not quite sure. Another theory is altered immune function, where essentially someone's immune system isn't working well enough or is working in a different way. So it doesn't quite recognize that endometriosis or the endometrial cells outside of the uterus is foreign, is abnormal. So it allows them to grow. And we also find sometimes increased cytokines in the peritoneal fluid of women with endometriosis as well. But the most likely reason is a combination of all the above. We still don't know per se exactly what goes on to cause endometriosis, but these are some of the things that some of the working theories we're working with at the moment. But what we do know is that it's predominantly estrogen dependent. And we think that estrogen in the early stages of development might transform the embryonic cells into endometrial-like cells, which then grow and develop in puberty. So just to mention as well that the grey slides are the slides that really do correspond with the learning objectives. The other green slides are more for interest and may help us to understand more what's going on with endometriosis. So as I've mentioned already, the endometriotic tissue responds to the cyclical hormonal changes in the menstrual cycle, leading to cyclical bleeding, which then leads to an inflammatory reaction and then can lead to scarring and fibrosis. But this doesn't exactly explain why someone gets period pain during with endometriosis. So there are sort of two branches that we can see. The first being pain due to endometriotic lesions, and the second being scarring and fibrosis and secondary lesions. So we'll just go through that one by one, and hopefully that helps to explain why the pain is so bad in endometriosis. So peritoneal lesions may induce inflammatory reactions and secrete inflammatory chemicals such as prostaglandins and cytokines, therefore leading to pain. Again, some people have deep infiltrating endometriosis, so deeply invading the walls and sometimes organs as well. And this can destroy the tissues and the nerves in the pelvis. Also, some may have chocolate cysts. I'll show you a picture of that later on as well. And if that ruptures, the contents of the cyst leak out into the pelvis, into the pelvic cavity, and also irritate the peritoneum. Now, with regards to scarring, if there's fibrosis, if there's adhesions in the pelvis, this can reduce the mobility of organs, therefore leading to pain occurring if there is any form of movement. And the organs don't move, wildly so, but there is some movement even as you move about in the day and as well. And if that's restricted by adhesions, then that could be the cause of pain. Again, if bowel gets adhesed as well, this causes dyschezia. This is the pain that Mariam was feeling when she would open her bowels whilst on her period. And if the uterus, rather than being antiverted, is retroverted due to adhesion as well, again, that can lead to pain opening bowels on her period. So just looking at the epidemiology, very briefly, it affects about 1 in 10 women of reproductive age, about 176 million women worldwide. It's thought to affect 2 million women in the UK, which is actually a similar number of women affected by diabetes. So it's quite a large number, to help you put things in perspective. But the exact incidence is unknown. Please, can you put your thoughts in the Slack channel as to why this is the case? I'll just wait for your responses. Yep, okay, so someone has said difficulty in diagnosing endometriosis, correct. Someone said misdiagnosis, again, very correct. Later on, we'll be discussing some of the differential diagnoses or some of the things that endometriosis can be taken for. Flora has said it's difficult to get a diagnosis, definitely. Misdiagnosed, patients not seeking medical attention, so not diagnosed, yeah, definitely, because if this is something you've had all your sort of reproductive life, you might think this sort of pain is normal. Oh, yes, Catherine has said thinking pain is normal. So exactly that. Exactly. So it's really important that people are aware that these symptoms are not normal, and there are things that we can do about it to help them. Perfect. Thank you very much for your responses. So it's an estrogen-dependent disease. That's why it usually affects women of reproductive age. If you're 9 years old and you haven't started your periods yet, you wouldn't have endometriosis, or we wouldn't say that or be able to really diagnose that. And again, postmenopausal women, because they've stopped bleeding on a monthly basis or on a regular basis, again, we wouldn't usually see endometriosis in them, or it may still be there, but they may not be symptomatic. And it approximately takes 7.5 years from the onset of symptoms to diagnosis for a myriad of reasons, a lot of what has been said already, but that's also quite problematic because things are getting worse in that time, and that's a long time to be going with symptoms that can be helped as well. And also the prevalence of endometriosis in women with infertility is about 30 to 50%. So it really does have quite massive effects as well. I must say as well that in about 80% of women with chronic pelvic pain, they do find endometriosis in those cases. And also endometriosis isn't always symptomatic. So I think they did a study and in laparoscopy in asymptomatic women, 20 to 50% had evidence of endometriosis of sorts. So it's very prevalent. So we're just going to discuss some of the risk factors for endometriosis: nulliparous, so never having had a baby; early menarche, starting your periods early or having a late menopause; having short menstrual cycles, less than 27 days; or just generally having high estrogen levels or greater lifetime exposure. Now, I've clumped these together because it essentially is pointing to greater estrogen exposure. If you've never had a baby, you've never had 9 months of not having a period, you've never had 9 months of not bleeding whatsoever, if you started your periods early, you're more likely to have more cycles in your life. If you have short menstrual cycles, you're likely to bleed more frequently. And these all sort of lead back to the etiology and may explain as well. So with every period, there's a greater chance that there may be a case of retrograde menstruation, so the blood backing out into the pelvic cavity. There may be a great opportunity for the endometrial cells to enter the bloodstream, into the tissue system, into the lymph system, and spread around the body as well. Another risk factor, menorrhagia, that's heavy bleeding, lasting, especially heavy bleeding lasting more than 7 days. Again, maybe greater opportunity for menstrual blood to back up into the pelvis and for endometrial cells to do so as well. Low BMI. Now, they're not exactly sure as to why this is the case, but we know the association exists. Family history of endometriosis. We know, as with everything, or as with most things in medicine, genetics plays a role. And we also find a 10-fold increased incidence of endometriosis in women who have an affected first-degree relative. So that could be a mom or a sister, for example. And also reproductive tract abnormalities. So because of how the uterus and the reproductive tract develops, sometimes things aren't entirely smooth, and the uterus sort of comes together like so. And if there's a horn or a septum in the uterus, that might also affect the flow of menstrual blood and may cause it to back up into the pelvis with retrograde menstruation. That's quite a lot of risk factors. I hope I've explained why. If there are any questions, drop them in the Slack channel at any point in time. Okay, some more Slack action. We've discussed some of Mariam's symptoms as well. So even if you do remember all of Mariam's symptoms, please can you put them again in the Slack channel? And so what do you think the symptoms of endometriosis are? I think we've covered most of them, but it would be good to go over them one more time. Dyschezia, yep, someone said dyschezia, that's correct. So pain opening your bowels. Yep, pain during the menstrual cycle, we've said that as well. Pain during sex as well, dyspareunia. Subfertility, pain that gets worse over time. Dysuria, perfect. Dysmenorrhea, again, as has been said, really good. Yeah, you're getting all the symptoms. Pain just before periods, stopping before period ends. Yep. Cyclical pain, perfect. So these are all chronic fatigue as well, excellent. So these are all symptoms that we can expect to find. So we've spoken about pain. It's often severe, it's cyclical, as with the menstrual cycle. And there are also gastrointestinal symptoms, so potentially diarrhea, constipation, other problems with the GI tract. Dysmenorrhea, painful periods, we've said. Dyspareunia, that's pain during sex. And the reason that this might be the case is if, for example, a lady has endometriosis in the pouch of Douglas, this area behind the uterus, and behind the uterus, between the uterus and the bowel. If there's any form of sexual penetration, for example, this area may already be tender and inflamed. And if that's close to the period where the whole pelvis is already quite inflamed anyway, that would be very, very painful for our lady Mariam. Chronic pelvic pain as well, dyschezia, pain opening the bowels. So if there are adhesions in the bowel, for example, or around the bowel can't move freely to let the feces through, and again, maybe a cause of pain. Dysuria, if there is endometriosis at the front of the uterus or in between the uterus and the bladder, or it's infiltrating the bladder wall as well, again, that can lead to pain too, for the reasons that we've spoken about already. Infertility or subfertility as well. And one of the reasons, or sort of the main accepted reason for infertility or subfertility, is because if there is endometriosis or adhesions around the fallopian tubes, there may be scarring. And scarring will therefore prevent the egg passing from the ovary down the fallopian tube into the uterus as well. If no egg is getting to the uterus, how are we expecting a pregnancy? There are other ways. There are ways that we can combat this through IVF, which I can talk about a little bit later. But it's also thought, as well as there being scarring, it's thought that the whole inflammatory environment of the pelvis isn't conducive to the egg and sperm. And also, as I've mentioned before, there may be no symptoms. Someone could be going about happily, not realizing they have endometriosis, and they wouldn't know because their periods don't give them any trouble as well. So as someone also mentioned in the Slack channel, symptoms may begin a few days before the period starts and generally ends with the end of the period as well. And I must stress this, there is a lack of correlation between the extent of disease and the symptom intensity. So you could have Mariam, well, we have Mariam here who's dealing quite badly with or is experienced quite bad symptoms from her endometriosis. If you were to look inside, if you were to do a laparoscopy, a keyhole surgery and look inside her pelvis, you might find speckles, like tiny bits of endometriosis here and there. Whereas you might have someone who maybe just gets the tiniest bit of pain opening her bowels around her period. You might open her up inside and find her whole pelvis is just flooded or just full of endometriosis as well. So there is a lack of correlation that we need to be aware of too. Again, time for Slack. How would you investigate Mariam? She's come to you, she's told you her symptoms, you have a feeling that it's endometriosis. What would you actually do to diagnose Mariam? Again, I'll wait for your responses in the Slack channel. Fantastic. So people are saying diagnostic laparoscopy. Perfect. Is there anything else you could do? Okay, someone else has said transvaginal ultrasound scan. Excellent. Laparoscopy. Everybody jump into laparoscopy. Okay, sweet. Fab. We'll talk about laparoscopy, but there are a couple of other things you would do before you get to laparoscopy. So if there's anything that you take away from today, even if you decide to forget everything about endometriosis, I really want you to take away this. This is really helpful when anybody asks you a question. So it might be a doctor on a ward round or on placement, or it might be in an OSCE setting or in finals. If anybody asks you, how do you diagnose or how do you investigate X person's symptoms, have a structure. And the structure we're using here is, again, you can find a structure that works for you. The structure we're using is bedside, bloods, imaging, and special tests. And that helps you, number one, look like you know your stuff because you're giving it in an orderly way. And number two, it helps you buy time if you're stuck, to help think about these things. So we'll sort of do that in Mariam's case as well. So the first thing that is so important, someone else has said routine bloods, pelvic exam, urine dip to exclude UTI, sexual health history, STI screening. Perfect. These are all really good. History is very important. From this history, Mariam's history, most of you, a lot of you already got that it was endometriosis. So getting a thorough history is just paramount. And I think it's said in medicine that, you know, the diagnosis comes from the history and the tests are just to confirm your diagnosis. Pelvic exam. This is also really important. For your safety and for your patient's safety and comfort, it's important to have a chaperone. If in the future a patient makes an allegation against you, the presence of a chaperone is really helpful in making sure you don't get into trouble. And again, this is an intimate exam, and it's important to put yourself in your patient's shoes as well. It's a very intimate exam. She may not want a male medical student in the room. Oftentimes people are okay with it because they know everybody needs an opportunity to learn, but it's important to be sensitive to people's cultural preferences and religious preferences as well. So where possible, those requests or those things should be honoured as well, and they may request a female clinician to do it. If it's not urgent, if it's not life and death, then it may be worth rebooking her in for an appointment or asking a female member of staff to perform that pelvic examination. Some of the things you might find are, you might find trigger points, areas of tenderness. You may feel potentially lumps of endometriosis. Highly unlikely, but it's potential as well. You might also feel cysts. You might notice that there's decreased mobility of the uterus and of the annexa, the ovaries as well. Or you might find nothing. You might find that it's a normal pelvic exam. The next thing, as has been mentioned in the Slack channel, is to do a transvaginal ultrasound scan. On this, you could find ovarian endometriosis, an endometrioma, chocolate cyst. I have a picture of that as well. Might potentially see ground glass appearance. Whilst an ultrasound is great because it's quite cheap, it's quite readily available. There are no X-rays or any form of radiation. There is less value in detecting smaller lesions. However, sometimes you can see telltale signs. So for example, can't believe I'm doing this, but imagine I'm a uterus, I'm a womb, and imagine my arms are the fallopian tube and my fists are my ovaries, are Mariam's ovaries. Usually if you're doing an ultrasound scan, you can see them, you can see their anatomy, you can sort of slightly move them around a little bit. If you find that instead in the ultrasound scan, the ovaries, the fallopian tube, everything is sort of stuck and tucked in behind the uterus, that's sort of a telltale sign that, hey, there's something more going on. There may be adhesions that's causing everything to sort of clump together, and will make you think a bit more about endometriosis as well. And the gold standard, as a lot of people have said, is laparoscopy and histological verification. This is an example of something you would see during laparoscopy in a person who has endometriosis. So just to orientate you, we have the womb, we're looking from above. We have the uterus here, we have the fallopian tubes here, the ovaries, and what's sort of in place of an ovary or disrupting the ovary. This is an endometrioma, ovarian endometriosis, or a chocolate cyst. So you can see it's been punctured and you can see this sort of chocolate sauce-like oozing out of it as well. And in situations like this, if this was to rupture, it would irritate the peritoneum, again, causing Mariam pain or causing someone pain. Also, we can see here, this isn't the nice pink that we're used to or that we should be seeing. We can see areas of red, looking quite red raw, and we can see whiter areas as well, and things just don't look very good. That's an example of something you might see. Again, here we have a red lesion on the peritoneum. We have matchstick lesions. Something else you might see, looks like someone's got a hot matchstick or sort of a cigarette type thing and just gone overboard in the peritoneum, in the pelvis. And you might see white fibrous tissue, white fibrous bands, again from repeated inflammation and scarring as well. And also this is another view of what you might see, just to reorientate you again, fallopian tubes, ovaries, and this is the uterus. Someone has mentioned routine bloods. Yes, also you would want to do routine bloods. Anytime anyone asks you what would you want to do, and you say bloods, be ready for them to ask you, what are you looking for in the bloods? So what would I be looking for in the bloods? One of the things is I'll be looking for anemia. Mariam hasn't said she has heavy periods, but in some people they do. So you want to do a full blood count for that. You'd also want to check out her white cell count. There may be an underlying infection going on as well, something to be aware of. So there are other things you can do just to be aware as well. And also someone has mentioned MRI. Now MRI is good, but we don't really use it in the diagnosing and the workup for endometriosis. Resources, it might be difficult to get a hold of an MRI or to use an MRI slot. It can be really expensive, and whilst it doesn't use any form of radiation, it's not something we use sort of first line. It can be used though, if we do open up a patient and we see there appears to be quite deep endometriosis. It can be used in the planning for a next operation to see what sort of areas may need to be resected, to see how deep really the endometriosis is going as well. So it has its role, but it's not something we use first line. We mentioned differential diagnoses, or we mentioned why it takes so long to get a diagnosis, and misdiagnosis was part of it. So we'll just run through very quickly some differential diagnoses for endometriosis. Pelvic inflammatory disease, that's an infection of the upper genital tract. That includes the womb, the ovaries, the tubes, and this is often caused by an STI, a sexually transmitted infection that was left untreated. Sorry, someone else has said, would you do a pregnancy test? Yes, also you would definitely do a pregnancy test. So in pelvic inflammatory disease, you'd have sort of lower abdominal pain. You may have heavier and more painful periods as well. And you might have pain urinating too. It could be a hemorrhagic ovarian cyst. Cysts are very common. Cysts are very, very common and often asymptomatic. But if a cyst was to bleed and then the contents were to enter the pelvis, that again could irritate the lining because you've got blood and fluid in the pelvis as well. That would likely be quite sudden pain too. In this case, it's unlikely to be ovarian torsion because in ovarian torsion, it's, sorry, with the lack of, okay, I'll answer questions at the end in just a moment as well. We're nearly there. We spoke about ovarian torsion, and that's essentially where the ovary twists on the ligaments that are holding it in place. And in this patient, you would find them to be very, very sick. They would look quite unwell. They'd probably be nauseous, potentially vomiting because of the pain. They might also have a low-grade fever as well. And the pain is quite sudden and just extremely, extremely severe. You wouldn't be expecting this on a monthly basis as well. Now, in this case, they may also have had, if you ask your history very well, you might also find that previously, in previous weeks, they had maybe a couple of days of sort of abdominal pain, but then it resolved. Most likely, that was the ovary twisting on itself, but then spontaneously twisting back as well. In these patients, you'd want to take them to theatre, especially if they're at the point of nausea and vomiting, to try and fix the situation before they end up losing an ovary. Primary dysmenorrhea could be a case of just really bad period pain cramps, but then not being really any underlying pathology. Could be a degenerating fibroid. Could also be an ectopic pregnancy. Now, this is in red. I guess ovarian torsion should also be in red because ectopic pregnancy you do not want to miss. Someone also spoke about investigating. Yes, you would also do a pregnancy test. And in times like this, it's so important. The history would also be different. In ectopic pregnancy, you'd find probably a one-sided, so maybe a left-sided lower abdominal pain. She may be bleeding a little bit, but spotting, and the blood won't be bright red. The blood will sort of be a brownish color as well. You might find that they look a bit pale if the fallopian tube has ruptured, or they're just feeling quite tired and fatigued. And the history, you'd ask, when was your last period? If they say 8 weeks ago, bingo, well, that's likely to be the case anyway. So yes, if anybody comes in with period pain or with any form of pelvic pain or abdominal pain at all, it's really important to do a pregnancy test. Even if they say, oh, I haven't had sex in so long, do a pregnancy test. Just do the pregnancy test is the way to go. Now, some non-gynecological differential diagnoses, it could be interstitial cystitis. Now, I want to stress that this is a really quite poorly understood bladder condition. We don't really know what causes it. We're not sure the best way to treat it, but this isn't a bladder infection. So it's kind of a misnomer, or maybe not a misnomer, but yes, it's not an infection. And in these patients, they'd have low abdominal pain. They might have urgency, increased frequency as well. There could be a chronic UTI, a urinary tract infection involved as well. Could be renal calculus. Remember, renal calculus pain is from loin to groin. If the stone is near the groin area, again, that could give pelvic pain. It could be a GI condition. So it could be IBS, irritable bowel syndrome. It could be IBD, inflammatory bowel disease. Remember, they're different conditions. IBS, again, causes a lot of diarrhea, constipation, cramping, abdominal pain. IBD has a completely different pathology as well. It could be diverticulitis. Again, you wouldn't really expect it in someone of Mariam's age. She's 24. Diverticulitis we often see in older patients, in older people as well. And that's when there's an outpouching of the colon wall. Some feces or a seed or something may get stuck in that outpouching and may get inflamed, causing pain as well. Musculoskeletal could be a pulled muscle, for example. But I hope you can understand why Mariam's case isn't any of these Some of these are one time only, some of these progressively get worse, but Mariam's is cyclical. It happens around the same time of a period, a couple of days before as well. Just some things to think about. Moving on to treatment. Please can you write in the Slack channel some things that you'd expect to treat Mariam with. I've also given you like another top tip as well. When discussing treatment, if anybody ever asks you treatment for something, especially in OSCE setting, remember this format, or remember these headings: conservative, medical, and surgical. Again, it just helps you to structure your answer and helps you try not to miss anything out. So yes, I'll be waiting for your answers on what you can use to treat endometriosis. Someone has said contraception. Excellent. We'll delve into that in a little bit as well. Pain meds, relaxation techniques, and the IUD, intrauterine device. Yes, I'm gonna press on the IUD aspect because one causes more pain and one helps. Medical, NSAIDs, fantastic. I love that you've taken on the conservative medical surgical approach. Medical, NSAIDs, progesterones, contraception, surgery, hysterectomy. Someone has said steroids. We don't use that in this case, but I see your reasoning because it's quite an inflammatory state. Analgesia, hysterectomy, laparoscopy, GnRH agonist, also by a specialist. Exactly, guys. Guys, yeah, you're getting all the points. So conservative. So that's sort of like hot water bottle, relaxation techniques, breathing. Some people also try and control their endometriosis through their diet. Again, not many studies have been done on this, but there is some talk about phytoestrogens and eating foods high in phytoestrogens, contrary to what you think, because it may act as an anti-inflammatory, and also it has an anti-estrogenic effect in women with endometriosis. But this is not gospel, this is not proven, but some people find that it helps. Medical. Again, well, first of all, we have non-hormonal, so simple analgesia, such as paracetamol and ibuprofen, NSAIDs, the non-steroidal anti-inflammatories. Now, a bit of a side note, if someone came in with purely heavy periods, you didn't think it was endometriosis, you just thought it was heavy periods straight up, you would offer them something in the NSAID family called tranexamic acid, and that helps to reduce flow by about 50%. If they had heavy periods and also quite painful periods, you would consider giving mefenamic acid, similar family too. That helps reduce flow, and it also helps with pain. If it was something purely pain as well as ibuprofen, if that doesn't really work, you can give naproxen, which is a stronger NSAID. Remember, you might need to give gastroprotection as well, because we know that NSAIDs lead you greater risk of ulceration as well. Something I must stress, the reason there's an asterisk there is because oftentimes doctors aren't entirely clear, or may not sometimes even know the best way to prescribe NSAIDs for these patients. And that is, you want to tell them to start taking the NSAIDs a couple of days before they can expect their period to come. Why? Why would it not work on day one of the period when they're actually beginning to bleed? Well, we've spoken about it being quite an inflammatory condition. And if you're having pain a couple of days before your period starts, we really do need to target that and reduce the inflammation in the pelvic area. So for those who are using NSAIDs, it's really important to take those a couple of days before the period starts. We also have hormones, as people have said in the Slack channel. We have progestogens, or the progesterone only pill. That's a pill that you take every day, non-stop, no break. You need to take it within a 3-hour window, else there's risk of falling pregnant. There's a newer one out called Desogestrel, which you have a 12-hour window to take. And this works quite well, but people don't really like it necessarily, or people may struggle with it because it might affect and increase someone's acne. They may find that they're bloating, they might have breast tenderness. They may also find changes in their mood as well. And I think the biggest reason people stop with the POPs is because of irregular bleeding. You may spot, you may not have a period, it may come, but just be a bit different. The next thing on the list is the combined oral contraceptive pill that contains both estrogen and progesterone. And I know I said that this is a predominantly estrogen-driven condition, but the combined oral contraceptive pill helps you space out your periods. So you can take pill packs back to back and then bleed, and then take pill packs again back to back. So whilst it doesn't completely eradicate endometriosis, it makes it so that you have pain less often. The Mirena IUS. Now, I saw someone say IUD, and I wanted to pull someone up on that. I can't remember who it was. The IUD, the intrauterine device, is, we call that the copper coil. Now, the copper coil makes periods heavier, and it can make them more painful as a result, but it works very well in terms of preventing pregnancy. There are no hormones in the copper coil. However, the Mirena intrauterine system, on the other hand, has low levels of progesterone. And this, again, with the progestogens, it's quite helpful. Some people may prefer this because it doesn't mean it means you have progesterone or progestogens in the local area rather than taking it in and having full body effects as well. And it sort of induces sort of that, how do I say it? A state in which it should help the endometriosis deposits to regress potentially. And it's also used as part of the treatment for surgery. So people who may have surgery, they may insert the IUS afterwards to help keep the endometriosis at bay, to prevent further or new growth of endometriosis, and to cause the ones that they couldn't quite get to shrink. Next on the list as well, we have gonadotrophin releasing hormone agonist, also known as Zoladex, and you might add HRT as well. Now, again, someone said this in the chat as well, if it's recommended by a specialist, this isn't something that a GP would prescribe. This would need to go through to hospital. And essentially, this puts Our Lady, Mariam, this puts a person in a menopausal state. I've spoken about endometriosis being a condition that affects people of reproductive state, women of reproductive age, shall I say. With Zoladex, I won't go into how it works, but I can give you some information on that later. You're essentially putting your patient in pseudomenopause, in menopause. So she won't bleed, but she will also have the symptoms of menopause, so hot flushes, potentially sweating at night, changes in mood as well, changes in libido, potentially hair loss too. So it's not an easy medication for patients to go on, and it's quite a large injection in the abdomen that has to be taken every 28 days. You might add back in HRT in order to hormonal replacement therapy in order to help with the symptoms. If your patient is really struggling with hot flushes, for example, then you may add a small back in to help. And also it helps, yes, I'll talk about HRT a little bit more later. And also we have, someone asked, Mirena coil used rather than copper? Yes, definitely. Mirena coil over copper. We wouldn't use copper in this situation because it would make her period pain worse. And surgical. We have conservative surgery. So that's with the intention of destroying all visible endometriosis, and there are different ways you can do that. This is quite helpful if someone is trying to have a family in the next couple of years as well, or in the next couple of months, trying to have a baby. Or we can do radical surgery, which essentially we'd remove the uterus, we'd remove the ovaries, and we'd remove the visible nodules of endometriosis that we see. This in itself works phenomenally for some people, but some people, it doesn't take away the chronic pelvic pain they may have because the damage may already be done. Also in these women that may have surgical removal of their uterus and ovaries, we'd also want to add back, we'd give them some HRT because it means they have no estrogen production at all. And in terms of protection for the bones, that's really important because if you have your ovaries removed at 25, you need to protect your bones because we know estrogen is important in bone health and also in heart health too. With surgery, it's not all easy. With any form of surgical procedure, whether conservative or radical, you have the risk of pain, you have the risk of infection, you have the risk of bleeding, you have the risk of damage to nearby organs. So for example, damage to bowel, damage to bladder, damage to the ureters, and you could also have failure of the operation. It may simply not work. And oftentimes, or sometimes we find that the surgery people go for sometimes just doesn't work, or the endometriosis grows back afterwards. So we're nearly there, guys, and then we'll do a quiz. Just going to quickly talk to you about some of the complications of endometriosis. We've spoken about infertility, cancer. Now, this wasn't something I realized was a potential complication until I was sort of researching for this virtual clinical placement. And there's potentially increased risk of ovarian cancer. We know that it occurs in higher rates in women with endometriosis, but the overall lifetime risk is still quite low already to begin with. Some studies suggest that endometriosis increases that risk, but it's still, again, quite low. And although it's quite rare, there's another type of cancer, endometriosis-associated adenocarcinoma, that can develop later on in life in women who have endometriosis. But again, these cancer risks are quite small. Now, the psychological impact. When we discuss in medicine, often we just see the person in front of us as a patient that needs to be given medication or given surgery. But we often forget that there is a psychological impact as well. Now, Mariam is 24. She's essentially been living with an invisible illness, something that she may have thought was normal initially. And it can be very debilitating. Some women with endometriosis find that they have to take the first couple of days off work because they're so crippled with pain. Literally, they're bleeding outside of their uterus into their pelvis. And also some people struggle with people not believing them. It's whilst preparing for this webinar, one of our members of our team spoke about a gynecologist that didn't really seem to believe endometriosis existed. He knew that, you can see it in laparoscopy sometimes, but he sort of thought people were being a bit extreme with their reactions to it and their demonstrations of pain, which sounds insane, which is actually, it's not, that's not right. Also, psychologically, having a delay in diagnosis, knowing that there's something wrong, but people not really believing you, also knowing your condition is likely to worsen. Even though we have all these things, all the treatment options available, the hormonal options only really put a stop to the endometriosis temporarily. If someone is to stop those hormonal treatments, those symptoms are going to come back, or it's highly likely those symptoms will come back. And also, the hormonal treatments that do seem to work quite well are also contraceptives. So if someone wants to have a baby in the next couple of years, they can't be on any of those. So they might feel a bit stuck in terms of treatment options available. Psychologically, going for surgery, that can be quite a big thing. And sometimes these operations are quite extensive, especially if the endometriosis is quite deep or has deeply affected, infiltrated organs. And also, we've spoken about fertility, subfertility, or infertility. Again, imagine how Mariam must be feeling. She's 24. She doesn't know if she can have kids later on, or she doesn't know if it'll be difficult as well. And that's quite a psychological burden for a 24-year-old to have, and younger as well. And yes, IVF is an available option, but IVF in itself is very expensive, a couple £1,000s as well. The success rate for a cycle is about 30%, 33%. It's about a third anyway. Not only that, it's quite emotionally tasking, having to inject yourself with hormones and go for regular scans and egg retrieval. And whilst also sort of, people don't really talk about IVF, it's quite taboo. So imagine doing that and also balancing a full-time job. That can be really difficult as well. And also, it can be just quite difficult overall. So I think it's really important for us as future clinicians, to remember that there's more to the patient than what we just see, and they're a part of society, and someone might be struggling with fertility and her family are saying, when are we having our baby, when are we having our grandson, when are we having our niece and nephew? So definitely always make sure you think about the person and the other aspects as well. Okay, right, it's time for a quiz. I'm sorry, I know I'm running quite close to time, but we'll do the quiz. Another study tip. Try and avoid looking at the answer options available when you see a question. Look at the question first, try and come up with the answer in your head, and then sort of self-check your answers when you see the answer options. I don't know if that makes sense, but I think this is called active recall, and it's definitely helped me through med school. Like, thankfully, thank God, had a couple of distinctions along the way, but it really helps to solidify your knowledge. Do you really know what you think you know? So question number 1 is, which group does endometriosis affect the most? And you can write 1, 2, or 3 in the Slack channel. There might be a poll as well. If there's not a poll, you can just write 1, 2, or 3. I'll be waiting for your answers. Oh, 2. Oh, speedy. Excellent. Yeah, women of reproductive age. And we've spoken about why, we've spoken about the menstrual cycle, and the role of estrogen as well, and just bleeding outside of the uterus. Next question. Which of these etiologies might explain rare cases of distant endometrial deposits? Retrograde menstruation, transformation of peritoneal cells, induction theory, hematological lymphatic spread, or altered immune function? Again, I'll wait for your responses. I'm seeing a lot of right answers for the first question, by the way. Excellent. The answers are coming through. Correct. Hematological lymphatic spread. We think the endometrial cells may somehow enter the bloodstream or the lymphatic system and spread around the body as well. Excellent. Next question. The extent of disease correlates well with symptom severity. True or false? Yeah, you guys are getting them all right. Yeah, it's false. Remember, like I said, someone could have really extensive disease, but quite moderate symptoms. Someone could have quite what you think is quite small disease extent, and they could have extremely severe debilitating symptoms. Fantastic. Next question. The gold standard for endometriosis diagnosis is? Read the question well. What's the gold standard? Excellent. Oh, I'm seeing a mix of 2s and 4s, so a mix of transvaginal ultrasound scan and laparoscopy. So the correct answer is laparoscopy. That's the gold standard. Transvaginal ultrasound scan can be helpful in trying to point you to a diagnosis, but it's not the gold standard because we can't actually see the endometriosis, and we need to see the endometriosis with our eyes or with the eyes of the telescope, and maybe even biopsy it as well. So the correct answer is laparoscopy. Next question. Fola Shade, a 29-year-old woman has suspected endometriosis. She's tried the progesterone-only pill in the past, which worked well initially, then seemed to stop controlling her symptoms. She would also like to have a baby in the next couple of years. What management option would you recommend? Combined oral contraceptive pill, the intrauterine system, Mirena, conservative laparoscopy, radical laparoscopy. Sorry, I must say, I don't know if I stressed it, that the intrauterine system, the Mirena IUS, is different from the copper coil. So make sure you give her the Mirena coil rather than the copper coil because you make things worse. Correct. The right answer is, what I was looking for was conservative laparoscopy. And the reason you would do that is because she wants to have a baby in the next couple of years. If you give her the Mirena coil, yes, fantastic. Her symptoms may get better, but that's a contraceptive. So she's not having that baby in the next couple of years, unless she's like the lady in, I think, Thailand who had a baby with the coil miraculously. So yes, we would want to do a conservative laparoscopy, try and remove the endometriosis that we can see, and give her a better chance at having a baby. Someone said combined oral contraceptive pill, not quite, because again, that's contraception. It could potentially help with the symptoms, but we need to also remember her fertility wishes, and she wants to have a baby soon. Final question, which of these reasons may explain why 34-year-old Priya, who was diagnosed with endometriosis 5 years ago, has not yet conceived despite trying since her diagnosis? Is it that her fallopian tubes are too scarred and damaged? Is it that sex is too painful to have regularly? Is it that she's been struggling with chronic pain and low mood? Is it that she's on treatment that also doubles up as contraception? Ooh, okay, I'm getting some ones. I'm getting some fours. Okay, interesting. Interesting stuff. So kind of tricked here, all of them really. She may be having really scarred fallopian tubes. She may have really scarred fallopian tubes, so the egg can't pass through that scarring to the uterus. She might be really struggling with pain during sex. Remember, I spoke about if there's endometriosis in the pouch of Douglas, the area behind the rectouterine pouch, the area behind the uterus. Every time she has sex, it could be very, very painful, so much so that she doesn't want to have, hey, Kerry and Shawneen, yes, yeah, it is all of them, sorry. And could it be that she's struggling with chronic pain and low mood? Yes, again. That may also affect her libido. If she's feeling low, if she's feeling depressed, if she's in pain all the time, she may not want to have sex. She is on treatment that also doubles up as contraception. We've spoken about this already. If she's on Mirena coil, if she's on the combined oral contraceptive pill or the progesterone only pill, again, that would be contraception and would prevent her from having a baby. I hope these questions are clear. I hope the answers are clear as well. So the learning objectives, hopefully we all understand what endometriosis is, and we all understand and recognize why it causes period pain. Hopefully we can all recognize it in a patient history, which loads of you have done amazingly. And hopefully I've got the ball rolling in your minds about the biological and psychological impact of endometriosis on these patients. And hopefully as well, you're able to describe treatment options for endometriosis, going through the conservative, medical and surgical structure that I've spoken about before. So, woo, sorry guys, around a bit over time, but we finished. Any questions? I'm gonna go through the Slack channel now. Does anybody have any questions? Please, you can write them in the Slack channel. Please don't, yeah, you can email me if you think of any questions afterwards. Also, this is a QR code for a feedback form. Would be really grateful for feedback. When you, I'm sure you're quite sick of feedback going through medical school, but we actually really need it. And I'm a new junior doctor starting work end of this month. Feedback would be really, really helpful, so we can teach other people as well. I can also drop the QR code, the link in the group chat. Intasar, would you mind dropping the link in the chat? There are some questions here. I'm going to answer some of your questions as well. I'm also quite conscious of time. Would laparoscopy also be able to diagnose adenomyosis? Adenomyosis is essentially it's almost like endometriosis, but rather than the endometrial cells being outside in the pelvis, it's in the muscular wall. It's in the sort of myometrial. It's in the wall of the uterus. And that being said, can you see the wall of the uterus through laparoscopy? No, we see the outside of the uterus, but not the wall of the uterus itself. Laparoscopy might still be used if they want to rule out endometriosis, and they might find that there's not really anything there. But history is also really important for adenomyosis, because endometriosis, you kind of get it quite young, or you start showing symptoms quite young. So from pretty much from when you start having your periods, or whatever age that might be, and getting worse going forward. Whereas adenomyosis seems to be more a condition of middle-aged women, and later on, so they'll probably be in like the late 30s, 40s. So history is quite important as well. Can you please explain again when tranexamic acid is used and when mefenamic acid is best used? Sure. Tranexamic acid, we use that if someone has really bad periods in terms of heaviness. So if someone has a really, really heavy period, pain isn't so much of a problem, or they can control their pain with paracetamol and ibuprofen, then we would give them tranexamic acid. That reduces flow by about 50% over a period of time. If someone has painful periods and heavy periods, so painful to the extent where it can't really be controlled with paracetamol, then we would give them mefenamic acid instead. Now with NSAIDs, we don't give NSAIDs together, so you wouldn't give tranexamic acid, naproxen, and ibuprofen. You'd basically kill the patient, because they'll have a stomach ulcer and that will not be very good. So you'd sort of pick one trial, see if that works, and make sure that they're using it the correct way. So using the NSAIDs before the period starts to help combat the inflammation. I hope that makes sense. We spoke about how endometriosis can cause problems with fertilization, but can there be issues with actually holding a pregnancy? Potentially, there may be issues, but again, we're not really certain. Spontaneous miscarriage is very common. It's extremely common. That's a whole virtual clinical placement in itself. And again, that's very common in the general population. It can be quite common in women with endometriosis. So potentially, yes, if that really answers your question. How do fibroids and endometriosis present differently? Fibroids, I'll ask a couple more questions and then I'll stop. Fibroids and endometriosis. So fibroids, that often presents with heavy bleeding. That also presents with quite severe period pain as well, and really bad cramping. But that pain starts at the start of the period too. Endometriosis, on the other hand, the pain often starts before the period, and it's a different type of pain. It's like that electric shock type sharp pain, whereas with fibroids, it's often more crampy type pain. As well, on examination, you can feel fibroids on an examination. You can feel a bulky uterus as well. So that's sort of how they may present differently. And in fibroids, because of the heavy bleeding, I'm talking about like flooding. They may potentially have flooding, clots, quite very, very unpleasant as well. And they might also feel like a dragging sensation if the fibroids are really big. If the fibroids are also massive, you might see, they might look a bit pregnant as well, because it's disrupting its growth. That fibroids are benign growths in the muscular wall of the uterus. So yeah, that again may distort the uterine cavity. Okay, I'm going to stop there because I've run over time. I'm really, really sorry. And yes, if there are any more questions, feel free to drop them in the Slack channel and I can respond to them throughout the day and a bit later on as well. Again, thanks guys. Would really also appreciate if you could fill out the feedback form too. I think we're either gonna have a small break. I think we're gonna have a 5-minute break actually. And then we'll move on to the next speaker about multiple pregnancy. Thank you very much.
Hi everyone, I'm Bronwyn. I'm going to be the next speaker. I just want to say a big thank you to Tolu for her great talk. We're just going to leave the slide up for 5 minutes. You guys all have time to fill in the feedback. And just a reminder that if you fill in the feedback for every talk today, you will get a certificate, which is good for your portfolio, and the feedback is great for ours. So I'll see you all in 5 minutes. Bye. Hi everyone, I'm Bronwyn. I'm a recent graduate of Newcastle University and a first year doctor. and today I'm going to be talking about multiple pregnancy. So just before we get started, can I just check that everyone can hear me okay? Because I'm not the greatest with tech. If you just post in the Slack or something, that should be fine. Thanks, guys. All right, let's get started then. So, like I said, today I'm going to be talking about multiple pregnancies. It's a topic that does get covered in med school, but I don't think enough. Every single obs and gynae practical exam I had, there was a woman with carrying twins there, and you often ask questions in the background of how twinning occurs and things. And it's an easy question to bring up in written exams as well. So I just thought it was a good topic for us to cover today. So here's what we're going to be covering. So we're going to come back to our patient, just so we can keep that carry on through. I'm going to be talking about the types of multiple pregnancy, the importance of the different types, why it occurs, and the most important thing associated with multiple pregnancy, a term called chorionicity, which is related to the placenta. And I'll go into that in a bit more detail. And then we're going to talk about management aspects. So for those of you further along in med school, that's going to be really important because we manage mothers with multiple pregnancies completely different to people who are carrying singletons, i.e. one baby. And then there'll be a quick quiz at the end. So again, if you've got any questions going through, just post them on the Slack and I'll try and answer them as best as I can. And like before with the quiz, if you just post your answers in Slack again at the end. So let's get going. So quick catch up with Mariam. She's now pregnant. So she underwent a successful round of IVF in her late 30s and is now pregnant at the age with twins at the age of 39. This age is going to be really important in a sec. So not only is she a high-risk mother because she's carrying twins, she's also what's termed as a geriatric mother. So that's any mother who's pregnant at the age of 38 or above. So both carrying twins and being geriatric puts you in the high-risk category, which means that instead of your care being midwife-led, it will be consultant obstetrician-led. And you're at more risk of various complications, so it requires more intense management. So we're going to explore twin pregnancies a little bit more. So I just thought I'd start out with some important definitions. I know they're a bit boring, but obs and gynae is kind of like a whole new language that you need to learn. Medicine itself is like that, but it has all these new terms as well. And if people haven't done obs and gynae before, if you're lower in med school, you might not come across them. So I just thought I'd talk through it. So gravidity and parity are basically the first thing you see in any pregnant woman's notes. So gravidity is the number of times a woman has been pregnant. So this can be any type of pregnancy. It could be one that was terminated. It could be a stillbirth. It could be a miscarriage. It's just, so it's every single pregnancy, any prior births and the current one. So if a mum, and then parity is the number of times a woman has given birth to a fetus with a gestational age of over 24 weeks. So that birth is regardless of whether it's a live birth or whether it's been a stillbirth. Provided the mother's given birth, she will have a parity number to reflect that. So for example, if we've got a brand new mother like Mariam is carrying 2 babies. So she will be G1 because it's only one pregnancy, but she's not had babies before, so she's P0. Once she's given birth, she will have had 1 pregnancy, so G1, but 2 children, so P2. So this is the way it's referred to in the notes. You'll just see it at the top, the mother's age and the gravidity and parity. It's also on the boards and all the obs and gynae wards. It's a really easy thing to understand early to kind of know what's going on with the patient. So specifically for twins, the next terms are really important. So zygosity, so that's the number of eggs. So this is important because it decides whether a twin is going to be identical or not identical and the risks that come with the different types of twins. So monozygotic means that there's been 1 egg and that embryo is split. So you're going to have 2 identical twins. And dizygotic means that there's 2 eggs that were fertilized at the exact same moment. So it'll be 2 non-identical twins. Chorionicity is the number of placentas. This is the most important bit, and I'll go into that more later. And amniosity is the number of amniotic sacs. As we know, the amniotic sac protects the baby and envelops it. So in some twins, they share an amniotic sac, and in some, it's two separate ones. Again, let me know if there's any questions on the sac, and I'll do my best to answer them. Or if I'm going too fast or too slow, just let me know. So the risk factors for multiple birth. So the two main ones are assisted conception and an older mother's age. Hence why, remember when I said it was important that Marion was 39? Basically, the older you get, kind of a woman's body starts firing off multiple eggs. Like the way it was described to me was that it's like the body's kind of instinct for reproduction is just desperately trying to make sure you have a baby to pass on your genes, that whole kind of like historical thing. So as you kind of come towards the menopause where you can't have a baby anymore, your body's firing off loads of eggs all the time in the desperate attempt to get pregnant. So therefore, it's more likely that multiple eggs will be released every cycle, and therefore more likely that multiple eggs could be fertilized. And then, as we all know, assisted conception is a super common way to have twins because there's multiple embryos being implanted, therefore you might make it to birth. However, in the UK, unlike other countries, it's now banned to implant over 2 embryos to try and reduce the effect of higher order multiple births. Like, you know, in like reality shows, might be like a mum with like 6 twins or something. Is to try and reduce that because that causes huge risk to the mother and to the embryos and fetuses. So we have laws in place now to protect against that. So genetic factors, like when people say twins run in the family, that's also important, and higher parity. So as we remember, parity is the number of times a woman's given birth. So if a woman's given birth more times, she's more likely to have twins later on. So you might have had like 4 singleton births. So a singleton is just 1 child, and then suddenly you have twins. You've just out of nowhere, and that might be due to your higher parity. Or because also as you go on having children, you're more likely to have them older, so that could also be part of a factor. So how does twinning occur? Like I said before, a monozygotic is when you have 1 egg, and that forms 2 identical twins. And dizygotic is 2 eggs, so it's 2 separate embryos, then for forming non-identical twins. So you've got, with identical twins, you've got 1 ovum, so the 1 egg, and 1 sperm, which forms 1 embryo. This embryo then splits, and the day it splits is really important because that decides how many placentas there are, how many amniotic sacs, and even in extreme cases, whether the twins are conjoined. And in non-identical twins, there's 2 sperm and 2 eggs that were fertilized at the exact same moment, forming 2 embryos, and these pregnancies are generally considered to be safer. So this is just a diagram to try and explain it a bit more. So as you can see on the left is the monozygotic process. And it describes how the different twins are formed at each division. So I'm going to go into what these terms mean if no one's ever seen them before and why they're important. And then on the right is the non-identical twins. And theirs is nice and easy. So basically with the identical twins, the later that the division occurs, the kind of like more risky the pregnancy can be, because as you can see, the later the division is, the more things the twins share, all the way up to being conjoined. So we've got, so here's the abbreviations that I was referring about. So the first type is a dichorionic, which means 2 placentas, a diamniotic, which means 2 amniotic sacs, which is abbreviated to DCDA. So you might see that in the medical notes on a ward round. And dizygotic, so that means 2 eggs. So this is when you've got the placenta and the twins were both embryos being fertilized at the exact same moment in time. And therefore they're essentially 2 different embryos with all of their own bits and pieces. So each twin has its own placenta and amniotic sac. And it's kind of like in the little ball, floating around as 2 separate beings. So this is the woman's uterus, and as you can see, there's 2 different amniotic sacs in 2 different twins. And so that can only happen in dizygotic twins, DCDA, digyzotic. And then you also have DCDA, monozygotic. So that's in the that is in the identical twins. But again, in this situation, the division has happened super early, so before day 3, allowing the twin to each form its own placenta and own amniotic sac. So therefore, it still has the DCDA status, which is generally considered a safer pregnancy. So the MCDA twins are the ones that are seen as a bit more dangerous. And I'm just going to go into why. So the monochorionic, i.e. sharing one placenta, and diamniotic, so again, two amniotic sacs. So this is only possible in monozygotic or identical twins. This entire page is only possible in identical twins, because as you can see from the previous diagram, these type of divisions only happen in identical twins. So in this one, this is when the division has happened slightly later. So you're sharing a placenta, which is really important later on, because there's loads of complications that can happen with that I'm going to cover. And these are the things you're most likely to be examined on, because it's things you can't miss as a doctor. So we'll go into that. But each twin is still in its own little protective bubble. And then we also have the monochorionic, monoamniotic, or MCMA twins. Say divide even later, so they're sharing more. So again, you can see they're both in the same bubble this time. So this is the first one we've seen where they're both in the same amniotic sac, sharing everything. And the final type is super rare, and it's conjoined twins. And these are the ones that you see kind of like on the news because they're so rare. And these twins share everything, right down to being conjoined, because the division happens so late. As you can see here in the picture, the conjoined twins are joined at the back. Let's go into how frequently this is. So let's say we start off with 1,000 twins. 700 or 70% of them are going to be zygotic. So that's the one where there's been two embryos fertilized at the exact same time. And then it can split, then it's a 50-50 chance as to whether they'll be a different sex or the same sex. But on the other side of the thing, 30% of the ones where there's been one embryo that's split later on, forming a monozygotic pregnancy. Of that, a third of them will be dichorionic. So that's when the split happens really early and you still end up with a DCDA twin, hence a kind of safer pregnancy. But because it's monozygotic, they're all going to be the same sex. But 2/3 of the monozygotic twins will end up being monochorionic. So this is the one where we have to do much higher level of management and much higher levels of surveillance. And that's what I'm going to go into on the next few slides. Of this, the vast majority are going to be MCDA. So that was sharing the same placenta, but different amniotic sacs. But these 10 here are all going to share the same amniotic sac. And of that, one has the chance of becoming conjoined. So if you've had 1,000 twins, there's a 1 in 1,000 chance that you'll have a conjoined twin. Right, so in my university, like I said, I graduated from Newcastle. I remember being assessed on this in my third year exam. I don't know whether other universities assess on it, because it's kind of something you'd more do as an obstetrician, but it was a question on my third year exam, so I thought I'd put it in. So it's how you assess chorionicity. So remember, chorionicity is the most important thing to look at for twinning. So it's the placenta. So if the placenta tissue kind of forms like a line between the two amniotic sacs, it's called a lambda sign. And that means that it's dichorionic, so two placentas. But if there's no placental tissue, this forms something called the T sign, which is seen in monochorionic twins, so this is how we know how many placentas there are and therefore how much surveillance and the degree of management that needs to be done for the twins. So I think it was like what sign on ultrasound shows you how many, if there's two placentas, and the answer was lambda sign, I think was the question that I had. So you'll never be asked to read an ultrasound, but just to kind of explain it a bit further, you can see the line between the two amniotic sacs of placenta here, and that's the lambda sign. And it's the T sign in monochorionic pregnancies. So this is the really important bit. So assessing chorionicity is easiest in the first trimester. So it's normally done at the 10 to 14 week scan. And then during this time, you can also choose to do all of your companion test screening and things like that. So it's all done in one place. So parents will find out at the 10 to 14 week scan that they're having twins and whether these twins are dichorionic or monochorionic, but they won't know the genders. But if we know the twins are monochorionic, we know that they're all going to be the same sex when they're born. But dichorionic, they could be either different sexes or the same sex. So Remember, ultrasound only determines chorionicity, not zygosity. So that's a really important point. Right, so this is why chorionicity is so important. So basically, if a twin shares a placenta, it shares all of the huge amount of vasculature that's in the placenta. So remember that the blood from the mother contains all the food, the nutrients, the antibodies, and it all comes through the placenta. And basically, if they're sharing the same placenta, one twin could be getting more of this blood than the other, and it could lead to something called twin-to-twin transfusion syndrome. And this is a super dangerous syndrome because it can lead to the death of at least one of the twins. And this is why we monitor so closely for it. So basically, if you can see in the picture, when they're sharing it, if one twin is taking more blood, the other one will start getting smaller and start starving. So it will try and donate blood to save its twin, but it could be too much. And the one who's not receiving enough blood just might not be receiving enough. So as you can see here, it affects 15% of monochorionic twins. So remember what we learned? 30% of twins are monochorionic, and of those, 15% may have twin-to-twin transfusion syndrome. So we really monitor monochorionic twins, particularly to try and catch this early, so then we can try and help it. And it's most commonly spotted at the 16 to 25 week period, so the second trimester. So that's why it's really important that we decide what type of chorionicity there is in the first trimester, ready to monitor in the second trimester. So it can be transferred disproportionately from one twin, known as the donor, to the recipient. So the donor will lose its blood volume, which can lead to brain damage and death because it's giving away its blood. The recipient gets an increase in blood volume, and this can overload the heart and cause heart failure, as well as polyhydramnios and oligohydramnios, which are important because that's the amount of fluid protecting it in the amniotic sac. And the key thing to take away is that without intervention, there is a 100% chance that at least one of the twins will die. So we need to spot this to try and protect the pregnancy. So the size discrepancy in twins. So twins themselves are normally about the same size as a singleton up until the third trimester, and then they drop about 10%. But once they're born, they kind of regain this size, it's fine. But if a size difference, so that's the size difference between like the two twins compared to a singleton. But if the size differences between the twins, which is completely normal at times, is more than 15%, we need to worry. So if, say, twin A is 15% bigger than twin B, then we need to figure out why. But if it's only 5 to 10%, we kind of will monitor it. And if it just stays that way, it's absolutely fine. So the reason why we need to investigate when it's over 15% is because if it's monochorionic, it could be twin-to-twin transfusion syndrome. And as we've just learned, there's a 100% chance of death of at least one of the twins. Or it could be placental insufficiency, and this would happen in dichorionic twins as well as monochorionic. So this is when the placenta isn't giving enough blood to one of the twins. So that's more a problem with the placenta itself rather than the way the twins are taking the blood. Or it could be a combination of one or two, particularly like in monochorionic pregnancies. So as you can see on the fetal growth chart, the growth for twin A is the line that keeps going up, and the growth for twin B starts petering off. So they're about 5 to 10% similar, and then around they just drop off. So what we've done so far is we've talked about our patient, we've covered what the different types of twins, we've covered the different types of why the placenta is so important in twin pregnancies, and now we're going to talk about how you manage twins and why it's so different. So do you remember at the start where I said that pregnancy with twins is considered high risk? That means that it's a consultant-led care with a specialist MDT. So they'll still have the community midwife come out and talk to them, they'll still have everyone else involved, but when they come to the hospital, they will see a consultant obstetrician every single time to check in and to monitor the twins. Not only that, but early ultrasound is essential, because remember, we need to figure out what type of placenta there is, and therefore how dangerous the pregnancy is going to be. And importantly, chorionicity is most accurately assessed in the first trimester. And if you want to take something away, this is one of the 3 main points to take away. And we need to identify the risk of a preterm pregnancy, because basically, if you think there's a chance that someone could give birth early, there's a lot of things we can do in singletons to try and prevent it. So we could do a mucus plug in the cervix, you can stitch the cervix, that type of thing. but none of this works with twins. Basically, the weight from a twin is so heavy in comparison to a singleton that the force of gravity just means that these methods aren't happening. So therefore, in these situations, we need to know whether there's a risk of preterm delivery. And basically, the woman will be on bed rest, lying horizontal, so that in the desperate effort to try and keep the twins inside as long as possible so they can grow as much. Because as we all know, when a baby is born preterm, it carries certain risks. And the closer to term we can get it, the better the health of the baby. So, and then the other important thing is the identification of something called IUGR. So this is intrauterine growth restriction. So this is when a baby just suddenly stops growing for some reason and we don't know why. It could be placental insufficiency. It could be that the baby's really sick. It could be that there's a problem with the umbilical cord. It could be a lot of reasons. But when it's spotted, we need to know why, because we may need to deliver ASAP. So it's more difficult to assess in multiple pregnancies because there's multiple twins to look at. It's kind of harder to measure them a bit on ultrasound. So therefore we have more ultrasounds. So in like a normal singleton pregnancy, there's, they won't do ultrasounds every 4 weeks like they will in multiples. They'll only do it about every 6 to 8. And importantly, the timing of delivery is different. So in a normal singleton pregnancy, we normally aim to deliver at 38 weeks, and up to 40, they'll then be induced because that's considered past term. However, in twins, we want to deliver a whole week earlier because it's safer for the twin, just that's what studies have shown. So we're looking to deliver at 37 weeks, either naturally, induction, or with C-section, depending on the lie of the twin, which is what I'm going to go on to in a little bit. And the other important thing to take away from this talk is that in a multiple pregnancy, every single complication of pregnancy, the risk jumps up. So we're talking about risk to the mother, so all the gestational diabetes, the anemia, the preeclampsia, increased risk, and the risk to the child. So that's both during pregnancy as well as during delivery. So if you ever ask in an exam what the risk of multiple pregnancy is, every single risk goes up. And that's another really important point. So then we talked about how monochorionic twins are really important because they share a placenta. So we're trying to avoid the risk of TTTS, but not only that, they're also a more risky pregnancy because they share a placenta, so they get extra monitoring. So from 12 weeks onwards, so remember we diagnosed the chorionicity at 10 to 14 weeks, so basically from the moment it's diagnosed, we have so many ultrasounds to monitor them. So it's every 2 weeks until 24 weeks, because that's the period when TTTS is most prevalent. And then every 2 to 3 weeks after that, because aside from the risk of TTTS, there's also the risk of intrauterine growth and also placental abruption, because one placenta to be feeding 2 babies is going to be massive. So there's the risk that that could abrupt and cause horrific bleeding to the mother and could potentially lead to death. So we need to monitor every bit of this pregnancy really closely. And that's why chorionicity is just so important. So in an uncomplicated monochorionic pregnancy, we actually want to deliver even earlier to try and prevent as many risks as possible. So from an uncomplicated monochorionic twin, we're looking at delivering at 36 weeks. And now you might be thinking, we just talked about twins, but this is multiple pregnancy. So in a higher, so it's referred to as a higher order multiple pregnancy when we have triplets, quads, and keep going up like that. And in that situation, there's a lot of kind of delicate thought around. I think in my entire time at med school, I maybe saw one higher order pregnancy that was above twins, and that was a woman with quads who'd had IVF. And she was coming in weekly for scans. Like there's so much monitoring because it's such a dangerous pregnancy. And because it's so dangerous, the consultant obstetrician may have the difficult conversation with the parents, depending on the order, about something called selective reduction. So this is the type of thing that you see on medical dramas, where like a woman comes in with carrying 5 babies, and because there's 5, they're not all getting the nutrients they need. So one may be severely growth restricted and quite ill. So then they may talk to the mother about having something called a selective reduction, which means terminating that one child for the improved health of the other 4. So that's a really emotive conversation that a consultant will have, but you may be present for, and it's a good learning thing. So again, in a higher order multiple pregnancy, it's probably more common in monochorionic because of things like IVF and stuff. However, it could also be dichorionic. It could be so because of that, it's still important to figure out whether it's a lambda sign or a T sign, and therefore the amount of placental tissue. But just like the monochorionic twins, these are delivered at 36 weeks because the older we get, the higher the risk. So this is years and years of studies that have decided what the optimum time is. So remember how I talked about the multiple delivery methods in twins? Basically, just like during pregnancy, how I said the complications increase also during the birth. So there's multiple ways for a mother to deliver, and there'll be more probably conversations about the risks with having a twin. Basically, twins are called twin 1 and twin 2, and it's to do with the order they're lying in the uterus. So twin 1 will be further down. And for those of you who've done obs and gynae, you know about how kind of like the engagement works with the head in the uterus ready to push on out. So that will be twin 1. So if twin 1 is lying what's termed as cephalic, which means the head is down. So when you give birth, you want to give birth to the baby's head first, because that's the way naturally it's easier to get the shoulders out, and a breech position, which is bum down, is quite dangerous. So if twin 1 is cephalic, there's a good chance the mother could have a vaginal delivery. But then if twin 2 comes, so if they deliver twin 1, nice and easy, but if twin 2 comes along and its head's not down, it might be its bum down, it might be a foot down, then they need to start thinking about an instrumental delivery or a C-section. If twin 1 isn't cephalic at all, then it's normally a C-section. They may try and turn it and do an instrumental, but normally it's a C-section for ease. So because of that, these conversations and birth plans need to be held really early with multiple pregnancy mothers, because there's just such a huge chance of having an instrumental birth or a C-section compared to a singleton. So because of this, an epidural is recommended in all multiple birth mothers, because even if they manage to give birth naturally to one baby, there's a likelihood that they will need an instrumental delivery or a C-section to the second twin. I remember how I said before that when there's a monochorionic baby, so one placenta, the placenta is huge because it's feeding two babies. Or if it's a dichorionic and there's two placentas, that's two hugely vascular masses that are in the abdomen. Basically, because it's more larger and the uterus is distended, so it's stretching this placenta, it can weaken it. So when you go through the pressure of giving birth, it massively increases the risk of postpartum hemorrhage or placental abruption. So a 10% chance of a woman having a postpartum hemorrhage, and a postpartum hemorrhage is a major bleeding event. You can lose liters of blood really, really quickly, and it can very quickly lead to a mother's death. So because of this risk of birth, in births, multiple pregnancies need to be monitored by consultants. There are just so many risks associated, and they need to be really giving birth in hospital, because if something goes wrong, they will not make it to hospital. These are conversations that you need to have with your patients. So just a quick thing to finish up before the quiz. This is something that I kind of like made a list of when I was at med school that I found really, really useful. So say you're in an OSCE and you've got a pregnant mother. These are just tips to talk about in the history and examination to make sure that you can show what you know you're talking about. You can show that that you really understand multiple pregnancy and the risks associated with it. So with the history, the key things, so aside from your normal birth history about like how many births before, how the pregnancy is going, etc., you want to ask these specific questions. So you want to know the details of the chorionis too. The mother probably doesn't know the term chorionis too. She might know if there's multiple placentas, but the easiest way to ask her is how often she's coming in for scans. Because remember how we talked about in monochorionic pregnancies, they're going to be coming in every 2 weeks for scans, whereas in dichorionic it's every 4 weeks. And so you'll know from that what the chorionicity is. So if you just phrase like, how many scans have you had? How often are you coming in? You'll know from that what the chorionicity is. So then you can tell the examiner when you're feeding back, she's an MC mother, so she carries this risk, and this risk, and show that you really know your stuff. Whether she knows the sex of the twins, because if the twins are two different sexes, remember that can only happen in dichorionic, diamniotic, dizygotic twins. So therefore there's absolutely no risk of the twins being monochorionic, and therefore no risk of twin-to-twin transfusion syndrome, which is the thing we worry about so much during pregnancy. Whether there's been any result from any screening tests, which is important every time, just like in multiple pregnancy, the result of the growth scans for each twin. Does she know if one twin is bigger than the other? Are they growing at a good rate? Are they growing slowly? Is she on increased monitoring for this? You want to know how well they're growing, because again, this could indicate twin-to-twin transfusion syndrome, or placental insufficiency, or intrauterine growth restriction, all things that are quite risky in multiple pregnancies. whether she's been told she's got a low placenta. So that means that the placenta would be lying at the bottom of the uterus or close to it, which could be really risky in a natural birth. And this is something a mother will be told at a scan, that her placenta is lying low, because there's a lot of things you can't do during it. For example, if you've got a low lying placenta, you can't be having sex, you can't be having anything that could potentially disrupt the cervix. So a mother will know if she has a low placenta, and it's something to know for the delivery plan, because you're most likely doing a C-section in a low placental birth. And finally, what are the plans for the delivery? Remember, there's so many risks associated with multiple pregnancy delivery that we want to have a birth plan in place and a plan for what happens in scenario A, B, and C. So a mother, because like a birth is a scary place. Like there's a lot of blood, there's a lot of mess, and a lot of pain. So you want to make sure that a mum knows that if, for example, her baby isn't lying cephalic, does she want turning? Does she want a C-section? If she gives birth naturally to one baby, does she want an instrumental delivery for the second one? Does she want a C-section? That type of thing. Like you need to have a really set plan in place to try and just make sure the mother's calm and knows what's going on. It's just so much more comforting. Checking the spot. And then finally, just for the examination. So again, just things to show that you really know what's going on. So remember how like in a normal birth examination, you'll measure the tape and normally the centimeter marks up with how many weeks there are. The mother's carrying at least 2 babies. It's going to be way bigger. So you can't just do the kind of like turning over the tape measure and this is how many weeks we think the accident matches up trick. That's something they'll catch you out on, because say you come in and you're not taking a history, it's just an OSCE. You go to measure it and the woman's at like 40 and really she's only 28 weeks ahead. But you haven't then done the rest of the twin examination. So you go and say, this woman's about to give birth. And actually she's really, really far from that. It's going to look really bad. So you just need to know how to examine a twin pregnancy differently. So the tape is going to be bigger. The woman's abdomen is going to be huge. She's carrying at least 2 babies growing in there and everything that goes with it. You need to be able to feel for the twins. So, you know, when you kind of do the lie thing like this and you're looking for the head, you're trying to figure it out. Try and find twin 1 at the bottom and try and see if you can feel the head, because that'll massively decide the delivery plan and it'll look really good to your examiner. If you can't feel it, don't worry. It could be lying transverse, which is when both babies lie like this. So nothing's hanging down. It could have its bum down. Just say if you can feel a head. If you can't feel anything, don't worry. But just if you can feel a head, that's a really good thing, because it does give the option of vaginal birth. And you can try and look for twin 2, but it's really hard. But maybe just go through the motions, and then if you can't find it, don't worry about it. Just if you can't find it, reassure the mother that like you're junior, you're just learning, it's nothing to be worried about. And then normally like when you wrap out the sonicade, it's all happy days because you can hear 2 heartbeats and then everyone relaxes. And that's the other important thing. When you're using the sonicade, you're looking for 2 fetal heartbeats. And normally you obviously put it to the right and to the left of kind of like lower down the abdomen, but that only works when the baby is lying down. If it's transverse, you're not going to hear them there. So if you can't hear it, just move it around the abdomen and just reassure them that while you're doing it, that you're in training, not to worry if you can't find it, because whoever is monitoring you will come ahead and just find it for them to relax after. But just treat the mother with a lot of respect and just reassure, because it's really worrying for them when they've heard the heartbeat before and suddenly you can't find it. So like I remember in one of my exams, I had 2 twins that were lying transverse, and I'd been super lucky in that I'd seen this exact mother 5 days earlier in clinic. So I knew that she had 2 twins lying transverse, but I was the only one that day that got it because I knew what I was looking for, because everyone else was kind of feeling for a twin lying cephalic and then forgot to kind of try transverse. So it's just important, if you can't find it immediately, just kind of keep trying up and down until you do find something. And then also a good thing to state in exams is that although you can hear the heartbeats with a sonicade, it's not the best tool to use because it picks up both heartbeats normally. If the twins are lying close, like if they're back to back, it's going to hear both heartbeats. So you need to say that you'd also want to do an ultrasound to check the viability, and that's just a really good phrase to remember. And finally, even though you're doing an examination on a mother with a multiple pregnancy, you still need to remember that this is an examination of a pregnant mother. So you still want to be checking for all the risk factors like preeclampsia, feel her ankles, look for any hypertension, check if she has any headaches, looking for anemia, and all the kind of generally bad things that we check for in pregnancy. And remember that all complications are more common in multiples. So when you finish your exam, you're going to want to state that, just to show the examiner that you know what you're on about. So that's it for now. And I'm just going to go into a quick quiz. So it's just 5 questions. And I'd love it if you could all get involved on the Slack. So it's the virtual elective Gynae and Sprogs Slack that was being used in the last presentation. So there'll be 4 options for each question. And I don't know if the Slack will be a poll, if it will just be posting your answer in it, whatever's easiest. And just let me know what you think. So question 1. What is the difference between gravidity and parity? Is it A, that gravidity is the number of successful pregnancies and parity is the number of births after 24 weeks? Is it B, gravidity is the number of births after 24 weeks and parity is the number of successful pregnancies? Is it C, gravidity is the number of total pregnancies and parity is the number of births after 24 weeks? Or is it D, that parity is the number of total pregnancies and gravidity is the number of births after 24 weeks. So I'll just give you a minute or so to post in the Slack your answers and then we'll talk through it. So it looks like a lot of you are going to answer C. Should we see if you're correct in a few minutes? God, everyone's going for answer C. And you're all correct. So I was trying to trick you by using really similar words like they sometimes do in exams, but gravidity is the number of times a woman's been pregnant. It doesn't matter if the pregnancy was successful, if it was terminated. If she's been pregnant, it counts towards her gravidity. And parity is the number of times a woman has given birth to a fetus with a gestational age of over 24 weeks. So remember, in multiple pregnancy, it could be G1, so 1 pregnancy, but P2 because she had twins. And you just need to know these terms when you're looking in the notes or when you're looking on the board on the ward, because then you can kind of spot the obstetric history and know what's going on. And also if you see someone's like P0 and only G1, they're normally a really good person to talk to because new mothers are always really excited and they'll often talk to you for ages. Whereas if you've got someone who has like multiple parity, normally like if you're watching a birth, it's like straight on out there because the higher the parity, like the more births they've had, the faster labour happens. So if like you're getting towards the end of a day and you haven't seen a live birth yet, see if there's anyone with multiple parity due to give birth, because it's a good way to kind of see a live birth and get involved. Whereas a new mother will be a much slower labour. So question 2, when during pregnancy is chorionicity best assessed? Is it A, the first trimester, B, the second trimester, C, the third trimester, or D, any time during the pregnancy? So again, if you just pop your answers in the Slack and I'll give you all a minute to do that. And again, it looks like you're all going for the same answer. And it's the correct answer, which makes me really happy because this is one of the main things I want you to take away from this talk, is that determining chorionicity is easy at the first kind of 10 to 14 weeks in the first trimester. And that's really important for all the management that's going to come after that. So I'm really glad that you're all getting that right. All right, question 3. What type of pregnancy can a twin-to-twin transfusion syndrome, or TTTS, occur in? A, all twins, B, dizygotic twins, C, dichorionic twins, or D, monochorionic twins? Again, I'm just going to give it a minute for the Slack to go. And again, it looks like you're all going for the same answer. And it's the correct answer. So well done, guys. You're doing really, really well. And this is another one of the main points, that monochorionic pregnancies are dangerous. And the big one that we look out for is TTTS, which affects 15% of monochorionic twins, which is actually really a lot. So, and it's normally spotted between 16 to 25 weeks or the second trimester, which is why they're going for monitoring every 2 weeks, because we want to spot it early and we want to manage it. And if any of you have like any questions about management, it's quite complicated, but I'm more than happy to like post some links in the Slack later. Just let me know. That's why I didn't put it in a slide, because it really isn't something that we get asked at med school, but like I can talk to you about it if you want. So question 4, if there is a size discrepancy between twins, at what point do you need to worry and consider dangerous causes? If the difference between twin 1 and twin 2 is over 5%, over 15%, over 25%, or over 50%. So again, I'll just leave it for a minute in the Slack and see what you guys have to say. Again, you guys are all getting it right. Oh, you're so good. So yeah, so if the size difference is over 15%, that's when we start to worry, and we need to figure out what's causing it. And it's normally either TTTS, but if the baby is dichorionic, that isn't possible. So then we're looking at placental insufficiency. But if it's monochorionic, we need to figure out what's going on, because that's quite bad. So that's when the obstetricians start getting worried, and that's when we really need to be assessing it quite closely. So well done, guys. And last question. Yeah, last question. What pregnancy complications increase in risk with a multiple pregnancy? Is it A, miscarriage, B, postpartum hemorrhage, C, intrauterine growth restriction or IUGR, or D, all of the above? Again, if you just pop it in the Slack. Again, you guys are all getting it. So yeah, this is the other of the 3 main learning points I want you to take away. Every complication increases in multiple pregnancy. So the 3 things that I want you to take away is that chorionicity is important, and we need to assess it in the first trimester. Monochorionic twins are a really high risk pregnancy because you're looking out for TTTS, and that all complications increase in multiple pregnancy, which is why the management is so strict and why it's under a high risk pregnancy group. So well done, guys. You've done really, really well. And also just to know what gravidity and parity are, because it'll make your life so much easier. So, and remember that a monochorionic pregnancy is much more dangerous than a dichorionic because of the shared placenta and the risks that are associated with it. And that with each order increase, so twins to triplets to quads, the risk further increases. So that'll be more close management and more close monitoring to protect the mother and her babies. So thank you for listening. If you've got any questions, if you just post them in the Slack, and I'll do my best to answer them. And if not, like Tolu said, if you could just scan the QR code, please. And this is a feedback form for my talks. It's different to Tolu's. And it's really good because basically we can take all this feedback when we apply for specialties to show that we've tried to do teaching, we can learn from it and make our teaching better in the future. And for you guys, if you fill in all the feedback forms today, you will get a certificate. So that can show that you've got like interest in the specialty, which is a big tick box when you apply for specialties. If you've not looked at kind of like what they look at interview, it's really important. So yeah, if you could just scan the QR code, that'd be great. And if the QR code's not working for you, I'll post the link on the Facebook event and in the Slack as well. But yeah, if you've got any questions, just post away in the Slack. I'll do my best to answer them for a couple of minutes. All right, so I'm just posting the link in the Slack for my form, and then I'll get on to answering questions if that's okay with everyone. So the first question I've seen is, what are the risks associated with polyhydramnios? So for those of you who don't know, polyhydramnios means poly, lots, hydramnios, water in the amniotic sac, so amniotic fluid. So in this situation, the baby has more fluid surrounding it in the amniotic sac than normal, and that has like associated risks, more to the baby than the mother. But the main risks that we worry about are cord prolapse. So that's when the umbilical cord drops through the cervix and can drop out of the mother's vagina or into the vaginal cavity. And that can cut off the oxygen to the baby and starve it. And that's something really important. Or placental abruption. So because of all the extra fluid, it's putting loads of pressure on the placenta and it can tear, causing a lot of bleeding to the mother. Premature birth. So it's just, I'm not entirely sure why it happens with the polyhydramnios, but there is an increased risk associated with premature birth and perinatal death. So that's when the baby dies in utero. I'll just see if there are any other questions going. Yeah, I'll just leave the questions open for the next couple of minutes before the next talk starts. So if you guys have any questions, feel free to post. And also, I think my details are on the Slack, so you can easily just message me separately if you've got any questions. Just let me know. And thank you all for listening, by the way.
Thank you, Bronwyn, for such an interesting talk. I think we might just have a 5-minute break and then I'll be back to talk about neonatal jaundice. So if you could fill in the feedback form and then we'll be back in a few minutes.
Thanks, guys. See you later.
Hi everyone. My name is Chloe and I will be talking about neonatal jaundice. First of all, can you hear me? Okay, I'll just check on the Slack. Let me know if we're live. Yes, lovely. Okay, so as I said, my name's Chloe. I recently graduated from Nottingham, and today I'm going to talk to you about neonatal jaundice. So we'll go through what it is, the causes, the management, and then we'll finish with a couple of case studies just to consolidate what we've been talking about. As with the other presenters, the session is going to be quite interactive again. So if you see the Slack logo, please head over to the Slack channel and get involved. And if you have any questions throughout, please feel free to ask them in the Slack channel and I'll get through them at the end. So let's get started. So the learning objectives for the session are to be able to describe normal bilirubin metabolism in newborns, to understand the common and serious causes, and to be able to describe the management and why it's important that any neonatal jaundice is treated promptly. So as a sneak peek for the case studies later, we're continuing with our patient Mariam, who's given birth to twins, but unfortunately one of them's become jaundiced. As we go through the presentation, maybe have a think about what could cause it and how it might be managed, and we'll come back to Mariam at the end. Okay, so first of all, just to get you thinking about jaundice, could you post in the Slack what you think a good definition of jaundice is? And I'll just give you a couple of seconds to do that. Yep, hyperbilirubinemia is a good answer. Raised bilirubin, increased concentration of bilirubin in blood, all very good answers. So the definition that I've got is very similar. Increased levels of bilirubin in the blood, which comes from the breakdown of hemoglobin. And as we'll see in a minute, there are many different causes of jaundice in neonates. Yeah, very good. Just looking through the definitions. Yeah, I think we've got it. Okay, so what I find useful when looking at a topic for the first time is learning what happens normally to then work out what's gone wrong to cause the disease. So to start with, we'll have a look at normal bilirubin metabolism. So when red blood cells come to the end of their lifespan at about 3 months, they're broken down in the reticular endothelial system of the spleen. And the hemoglobin in the red blood cell is broken down into heme, globin, which is the protein part, and iron. And for this bit, we're just going to focus on the heme. So the heme is converted into a substance called biliverdin, which is then converted into unconjugated bilirubin. This unconjugated bilirubin is bound by albumin in the plasma and travels to hepatocytes in the liver, where it's conjugated by an enzyme called glucuronide transferase. And then because this conjugated bilirubin is now soluble, it's excreted in the bile, goes down to the bowel, and then the bacteria in the bowel convert the conjugated bilirubin into a substance called urobilinogen. And then for the body to get rid of this urobilinogen, it's converted to stercobilinogen and excreted in the stools. So most of the urobilinogen's excreted in the stools, but it also it travels to the kidney and is excreted in the kidney, and some of it is recycled back to the liver and then undergoes the process again. So just to go through that again, so red blood cells are broken down in the spleen to form biliverdin and then unconjugated bilirubin. The unconjugated bilirubin travels to the liver where it's conjugated by the liver, travels to the gut, gets converted into urobilinogen, and then there are three things that happens to this urobilinogen once it to be excreted from the body. So most of it is excreted in the stool, and it's the stercobilinogen which actually gives stool its brown colour. The other way is that it goes to the kidney, is excreted by the kidney, and then the third way is it undergoes enterohepatic recycling and goes back to the liver and goes through the process again. So going back to the definition that we've just spoke about, jaundice is caused by increased levels of bilirubin in the blood. So it's this system and this enzyme that gets saturated, so the body can't get rid of the excess unconjugated bilirubin, and that's what causes the jaundice. So now we know a bit about why jaundice happens, let's have a look at the causes. So if you head over to the Slack channel and name as many causes of jaundice as you can. And this is jaundice in babies, not in adults, because there are slightly different causes. Lovely, hemolytic anemia, yep, that's a good one. Breast milk jaundice, yeah, biliary atresia, very important. Rhesus disease, hemolysis. Stephen said categorised into prehepatic, hepatic and post-hepatic. I personally don't categorise it this way, but that might be how you learn how to do it. Hypothyroidism, physiological jaundice, Kriegler in the jar, very good. So it looks like lots of you know a bit about this already. So with the causes of jaundice, I like to split them into the time after birth that they present. So presenting within 24 hours of birth, we've got hemolytic disorders like rhesus or ABO incompatibility or G6PD deficiency, where generally red blood cells are being broken down prematurely, which causes the levels of bilirubin to rise and the body not being able to cope with the increased levels of bilirubin, which causes the jaundice. And you've also got congenital infections such as your torch infections, so toxoplasmosis, rubella, cytomegalovirus, herpes simplex, and then you've got a couple of others like syphilis and varicella zoster. And then jaundice that presents between 24 hours and 2 weeks of age, we've got causes such as physiological jaundice, as you said, breast milk jaundice, infections, UTIs can present this way. So infection causes jaundice if the baby has reduced fluid intake, if their liver function starts to decrease and there's a bit of hemolysis going on, that can cause jaundice. And some other hemolytic disorders can also present during this time, so they're always important differentials. And then as someone mentioned, we've got Kriegler in the jar and polycythemia. And then moving on to jaundice that presents over 2 weeks of age, we can split these into whether the jaundice is conjugated or unconjugated. So in the unconjugated, sometimes physiological and breast milk jaundice present or are prolonged over 2 weeks of age. Some hemolytic anemias can present at this age. And also after 2 weeks, pyloric stenosis is an important differential. And you'd probably consider that if you had a history of a child who projectile vomits a lot, you would consider pyloric stenosis as the diagnosis. And then if you find that the jaundice is conjugated, you might consider differentials such as bile duct obstruction and neonatal hepatitis. So as you can see, there are loads and loads of different causes of jaundice, and we can't go through all of them now because we'll probably be here all afternoon and probably most of the night. So I'm just going to cover 2 causes today, which are G6PD deficiency and physiological jaundice. So before we start talking about G6PD, I just want to see if anyone knows anything at all about G6PD. So I've just seen that Tess has posted, can you repeat what physiological jaundice is? I'm going to go into that in more depth just after G6PD, so I'll do that afterwards. So does anyone know anything about G6PD to start with? Beans, yeah, beans. Enzyme deficiency, yeah. Fava beans, yeah. Okay, so during most of medical school, the way that I remember G6PD was anytime there was an exam question that came up and it was an unwell child that suddenly presented to A&E, maybe the day after eating loads of broad beans or fava beans at a family party, is always G6PD. So in G6PD, it causes a hemolytic anemia where red blood cells are broken down faster than they can be replaced because you're lacking the glucose 6-phosphate dehydrogenase enzyme. It's more common in males and those with a Mediterranean or Middle Eastern background. So the symptoms include jaundice, dark urine because you've got lots of unconjugated bilirubin because that enzyme becomes saturated and can't conjugate all of the bilirubin that's been broken down because of the been formed because of the hemolysis. Fatigue, shortness of breath, tachycardia. So generally it's self-limiting, and the main way to treat it is to avoid the triggers, which can be broad beans, fava beans, aspirin, antimalarials. Some antibiotics can cause hemolysis in G6PD, so quinolones, sulfonamides, and nitrofurantoin. So generally, as I said, it is self-limiting. Treating the cause, such as the infection, or removing the triggering antibiotics is sufficient. But if it's severe, the child might require a blood transfusion or dialysis if it's given them a kidney injury. So moving on to physiological jaundice, this is slightly different because it's not a process that's gone wrong. It's a normal physiological process in babies that causes the jaundice, and there's a few factors that contribute to this. So first of all, babies have a higher concentration of red blood cells than adults do. So there's more red blood cells that need to be broken down, so there's an increase in bilirubin. Secondly, babies' red blood cells have a lower lifespan, so they only last for 70 days compared to 120 days in adults. So therefore you're getting a higher turnover of red blood cells and more bilirubin being produced. And finally, adults are pretty good. As we saw, the liver conjugates the bilirubin so it can be excreted, and adults are pretty efficient at this process. But babies, their liver is much slower, so it takes longer and it's a lot more difficult for them to conjugate the bilirubin and get rid of it out of their system. So the levels of bilirubin in their body builds up and causes and contributes to this physiological jaundice. So how to investigate neonatal jaundice? So with any good consultation, you'd start by taking a history. You could head over to Slack. Let's pretend that I'm a mother of a baby that I've brought in who's suddenly turned jaundiced. What sort of questions do you want to ask me? onset, good. Family history, yeah, that's really important. See if any other babies in the family became jaundice very quickly. And one thing I forgot to mention is that physiological jaundice is very, very common. So it happens in around 50% of babies. So it's likely that babies of the same family experience jaundice. When did it start? Are they still eating, drinking, passing urine and stool normally? Yep, that's really important because we can tell how well or unwell a baby is from that. Urine and feces colour, yeah, definitely. Delivery history, that's really important. Vomiting, good. Breast or bottle feeding, good, so we can pick out our differentials. So yeah, you've got pretty much all of the questions that I'd say. Also, what age they were born at, what their gestational age was, is important to know as well. And we'll find out a little bit why later. So you've got the baby, so you'd also like to examine it. So you'd take some observations. A little side point here is that observations, what's normal for a baby in observations is very different to what we're used to in adults. So definitely have a look and check and familiarise yourself with what the normal observations are at different ages throughout childhood, because that'll be very useful. So during your examination, you can also see if you can see the jaundice, if you can see it in their sclera, in their skin. Check the tone of the limbs, and also check the nappy to see if there's any dark urine or pale feces. So other investigations that you can do, it's not an exhaustive list, but it will keep you going. So you can check their serum unconjugated or conjugated bilirubin, and that will give you a clue as to the diagnosis. Look at their packed cell volume. If it's low, it indicates that there's some hemolysis going on, which might give you a clue as to what the cause is. FBC and blood film. Do a direct Coombs test. If you're worried about G6PD, you could do a G6PD level. And then if you think it might be an infection that's causing the jaundice, you do all the normal things like blood cultures, lumbar puncture, urine dip, CRP and all those things. So then we've looked at the causes and we've looked at the investigations. Let's have a look now at how we manage it. So if you've had your paediatric placement, you're probably quite familiar with this graph. So on every paediatric ward, there'll be a graph that looks like this that tells you how you would treat a baby with jaundice. So you plot their serum bilirubin along the y-axis and their age in days along the x-axis. So there's two main ways of treating neonatal jaundice, and they're phototherapy and exchange transfusion, and we'll go over those in a minute. So once you've plotted what their results are on the graph, you can then see which treatment option is the best for them. And one thing also to note is you need to know how many weeks gestation they were, because the threshold changes. So for this graph is for 38 weeks gestation. And as you can see, the thresholds are a lot lower for treating the jaundice and hyperbilirubinemia if the baby was born before 38 weeks. So at 30 weeks, the thresholds are a lot lower. So one way that we can treat jaundice is by phototherapy. So the principle of this is that the baby is placed in an incubator under a blue-green light, and this helps to conjugate the bilirubin into a water-soluble pigment that they can excrete via the urine. So obviously no treatments come without side effects or risks. So for this treatment, the baby's usually just in their nappy because you want to expose as much of the skin as possible to the light. So this does come with the, so they're not able to maintain their own temperature, and you can't maintain it with blankets or anything. So the incubator is generally kept warm. The baby can come out in a rash and they can experience some discoloration of their skin, but these side effects tend to be transient and temporary, so they will go after a while. The other way for treating jaundice, and used for babies that have higher serum levels of bilirubin, is by exchange transfusion. So this treatment's a little bit more risky and a little bit more complicated than phototherapy, but it's also quite an effective treatment. So donor blood is given to the baby via a vein on their arms and legs or through the umbilical vein, and you usually give twice the baby's blood volume as donor blood, and then at the same time as you're giving the donor blood, you're removing the same amount of blood of the baby. So you're exchanging the baby's blood for the donor blood. So you generally use this to treat diseases like sickle cell disease or polycythemia, when there's either a problem with the shape of the red blood cells or the makeup of the blood, because this helps to alleviate the symptoms because you're giving the proper blood from the donor. And you can also use intravenous immunoglobulins instead of exchange transfusion, but this is a lot more expensive and it has different side effects. So it would be decided and initiated by a specialist, so I'm not really going to go into it now. So last but quite importantly not least, because this is quite an important slide, we're going to look at why it's important to treat jaundice. So does anyone know why we need to treat the jaundice first of all? Perfect. A lot of Kernicterus, and that is exactly why we need to treat the jaundice. So we want to avoid this condition called Kernicterus. So unconjugated bilirubin can cross the blood-brain barrier and can build up in the basal ganglia and the brainstem, and cause damage really. So the symptoms include poor feeding, a high-pitched cry, they can have apneas, they're quite lethargic, they can lose their muscle tone, which is why when you get a baby with jaundice, it's important to examine the tone in their limbs. Like in textbooks and things, it will say that the tone is like a rag doll. So they're very floppy and they can't hold positions. Seizures and coma, as well as muscle spasms that can cause arching of the back. That's quite characteristic of Kernicterus. But thankfully, it's quite an uncommon condition nowadays because we can pick it up and treat it sooner. So to manage Kernicterus, you basically want to treat the jaundice. So if you can treat the hyperbilirubin anemia, you can stop the high levels of bilirubin damaging the brain. But unfortunately, if you don't treat it in time, you can get complications like cerebral palsy, hearing loss, learning disabilities, which will be permanent for this child. So just to consolidate what we've talked about, we're just going to go through a couple of case studies now. So if you're able to join in the Slack channel, it'd be really good. And then we'll carry on. So you're the F1 on the paediatric ward. You've just finished a morning ward round when you're bleeped to A&E to see Sophie, who is a 10-day-old twin who's been brought in because her health visitor thought she was jaundice. On walking into the cubicle in A&E, Sophie looks settled in her mum's arms. Her mum's Mariam, who we've met before. Her observations are her heart rate is 142, her respiratory rate is 34, blood pressure is 70/50, and her temperature is 37.2. She appears to have normal tone in her limbs, but her sclera are yellow. While taking a history, her mum tells you that the twins were born at 34 weeks by caesarean section 10 days ago due to Sophie's heart rate dropping during labour. She tries to breastfeed both Sophie and her brother, but usually has to top up their feed with formula milk. However, both the twins are doing well and gaining weight slowly. So given the history and what you found in examination, which cause of jaundice is most likely? So A, rhesus incompatibility, B, pyloric stenosis, C, physiological jaundice, or D, hypothyroidism? Hopefully the question will pop up on the Slack soon. Lovely. We're going fancy this time with a proper poll. So great, looks like lots of you are getting the right answer. I'll just give you a few more seconds. So yeah, as you've all said, the right answer is physiological jaundice. So this is the most likely because, as I said in the history, the baby is 10 days old, and rhesus incompatibility presents before the age of 24 hours, pyloric stenosis is after 2 weeks, and hypothyroidism is also after 2 weeks, but you'd have hoped that it would have been picked up in the heel prick test before it got to that point. But yeah, well done, guys. So next question. So we admit Sophie to the paediatric ward for further investigations and blood tests, and her serum bilirubin level comes back at 276 micromoles per litre. So if you plot her age and her serum bilirubin on the graph, which is the most appropriate treatment for Sophie? Is it A, no treatment, B, should we give her phototherapy, should we give her exchange transfusion, or D, should we give her intravenous immunoglobulins? Okay, there's a few answers coming in. Good, nice to see you've all been paying attention. So the right answer is B, phototherapy. So as you can see, as I've plotted the little red dot for where this should be, so you can see it crosses the threshold for phototherapy, but is not yet high enough for exchange transfusion. So Sophie's mum, Mariam, gives informed consent for Sophie to undergo phototherapy. Which one of the following is correct? Sophie should only wear a nappy. Sophie doesn't need eye protection. Her bilirubin level will be back to normal within an hour of phototherapy. Her bilirubin level should be checked hourly. Which one is the right answer? A few mixed opinions on this one, a few people changing their minds. Yep, you're all correct. Sophie should only be wearing a nappy. And the reason for that is you want to allow the light to get to as much of their skin as possible so it can be absorbed. So they should only be wearing a nappy. B is incorrect because Sophie should be wearing little goggles. If you get a chance to see, if you're on a paediatric ward, I'm sure there'll be a baby who's having phototherapy at some point. So go and have a look because they have these little goggles that they have to wear. C is incorrect because it will probably take a day or two on the phototherapy for her bilirubin level to go back to normal. And D is incorrect because her bilirubin level should be checked every 6 to 12 hours to see how effective the light therapy is. Okay, so over the next few days, Sophie's bilirubin levels steadily fall and she's discharged 3 days after being admitted. So well done, guys. And then our second case study. So one of the nurses from the postnatal ward bleeps you because they think that Joshua, who was born 4 hours earlier, looks a bit yellow. You go and examine him and confirm that he looks jaundiced. You take a bit of a history from Mum, and Mum says that Joshua was born at term and there were no problems during the birth. She says Joshua's had one wet nappy and she noticed that the urine looked dark since the birth 4 hours ago. So given the time frame, which of the following do you think is the most likely diagnosis? You're all very good at this. Very decisive answer. So, yeah, great, you're all correct. So Joshua was born 4 hours ago, and of the causes that I showed you at the beginning, only G6PD is the only cause on the list that presents before the age of 24 hours. So breast milk jaundice can present anywhere from 24 hours to 2 weeks. Pyloric stenosis is after 2 weeks, and Kriegler in a jar is between 24 hours and 2 weeks old. So you contact your registrar who comes to take some blood tests. Which is the enzyme that's defective in G6PD deficiency? It's a bit of a trick one. Not a trick one, it's tricky. Got some responses filtering through. Yeah, and again, you're all correct. So the defective enzyme is glucose 6-phosphate dehydrogenase. So you get the blood test results back, and Joshua's bilirubin level is 210 micromoles per litre. You plot this value on the graph. I think that might be wrong, actually. Yeah, can we miss out? It's not 210. Can we do it if the... Yeah, that's right. Okay, yeah, that's fine. Sorry, I was just doubting myself. So yeah, Joshua's bilirubin level is 210, which is the most appropriate treatment for him. Do we watch him wait? Do we give him phototherapy? Do we give him exchange transfusion or kidney dialysis? So there's a couple of answers that are popular at the moment. Just wait for a few more answers. So this time we've got a 70%, 30% split. So the right answer is exchange transfusion. As you can see, if we plot his value on the graph, then he's well above the threshold for exchange transfusion already. If we watched and waited, it's likely that his serum bilirubin would just be off the scale and probably cause some damage. So it's best that we get in as soon as possible to give him treatment. So at birth, Joshua was 3.2 kilograms. For the exchange transfusion, the amount of donor blood needed is twice the baby's blood volume, which is calculated at 90 ml per kilogram. How much donor blood do we need to give Joshua? I'll just give you a minute or so to work that one out. So again, we've got some split answers. Okay, still a few people voting. So the correct answer is 576 millilitres, because you want to find, so the total blood volume is 3.2 kilograms times 90 ml, which is 288 millilitres. And then you need twice the baby's blood volume for the donor blood. So you need to times 288 by 2, which gives you 576. So final question. Over the next few days, Joshua's condition improves and his bilirubin level drops to 150 micromole per litre, so he requires no further treatment. Which of the following drugs would you advise Joshua's mum to avoid giving him, as it may cause hemolysis? Is it ibuprofen, aspirin, codeine, or paracetamol? Fantastic, you're all correct. You want to avoid giving aspirin, as well as some of the other things we discussed, so broad beans, fava beans, antimalarials, and some antibiotics. So that's the end of my presentation. So in summary, we've covered that there's many causes of neonatal jaundice, and we classify them according to the time after birth that they present. We've looked at the different ways to manage jaundice depending on what the bilirubin serum levels are, and we know that we need to treat jaundice promptly to avoid Kernicterus. So thank you very much for listening to my presentation. I'd be really grateful if you could fill in the feedback for me, and we can get those certificates to you if you filled in all of our feedbacks. If you've got any questions, please put them in the Slack channel, or you can email me after the session. So I'm just going to check the Slack channel, see if there's any questions. So Bethany's just asked, if the mother's planning on breastfeeding, does she also need to avoid aspirin? That's a really good question. I'm going to look that up and I will get back to you during the next presentation if that's okay. And Mohammed's asked, what is breast milk jaundice? So breast milk jaundice is just jaundice. So as we talked about physiological jaundice, it's similar to that, but it's more common in babies that are breastfed. Just for some reason, the breast milk causes them to become jaundice, and it usually resolves after a couple of weeks or so, and the mother can continue breastfeeding and it's completely fine. Again, Kelso, I'm not completely sure about the answer to your question. If the mother has fava beans before birth, is that what causes G6PD to show up in the first 24 hours? I'm not sure, so I will go and see if I can find out for you. Okay, so I think we're going to have a bit of a longer break now, and we'll come back to you with Intasar's teaching on common respiratory conditions at 4 o'clock. So I hope to see you there.
Hello guys, can you see me? And can you hear me? Let me know if you can hear it and see me. Yep, brilliant, brilliant. Okay, great. So we're going to be talking about today. Okay, I'll give you a minute. I'll give you another minute because my talk's not supposed to start until another minute. So I'll give it another minute, and then I'll go ahead and begin with this. We're going to be talking about common respiratory infections today, and I'm a fourth-year medical student studying at Birmingham at the moment. And I do have a big interest in academia and research and pediatrics, so this is why I chose this topic. So it's already 4, so we'll go ahead and start this topic. So we'll be covering today about the treatments and key presentations of bronchiolitis. We're going to be looking at the ways to identify and manage croup, and we'll discuss what croup is and all that, to know the presentation of COVID in children, and to be able to identify patients with Kawasaki disease. Now, the first thing is I'm going to give you the overall layout of how this is going to run. So we're going to have the general pathophysiology. We're not going to go into the depth of anything. We're not going to talk about neutrophils and CD4s and CD8s. We're not going to do all of that, but just the general pathophysiology behind that infection. Then what we'll do is talk about a case study. So it's going to be quite interactive. I'm going to be asking you to contribute, talk about the history, etc. And lastly, we're going to be talking about the sort of treatment options and management. We're not going to delve too much into investigations because a lot of these are more clinically based diagnoses. So the first part is going to be talking about bronchiolitis. So bronchiolitis in itself is it's in the name itself. So we're talking about the bronchiole. So we have the trachea, and then when this bifurcates, we have the primary bronchus right and left, and then we have the bronchioles, and then we have the terminal bronchioles. And usually in the terminal bronchioles, you have this sort of inflammation, and that's where you get bronchiolitis. And usually this happens when they're less than 2 years old. A similar disease called bronchitis and even asthma usually affects a slightly higher up, but in that sort of region, in the bronchioles, and that's where you get the asthma sort of symptoms. And usually they happen when they're more than 2 years old. The most common cause is a disease called respiratory syncytial virus, but other causes can be rhinovirus and parainfluenza virus. So if you look at what's happening, we get a mucus hypersecretion in that area. And what that's causing is that you can see that air is coming in, but air is not able to leave, okay? So in this sense, for example, so this is one diagram, but there's another diagram I drew. So this is my own animation. So if you can see here, where if there is a complete blockage due to that hypersecretion, what happens is that the alveoli here starts to collapse, okay? And that's what we call atelectasis. Now, if there's a small, if there's a narrowing, so what happens is air is getting in, but actually air is unable to easily get out. So you get a widening of these alveoli as well. So you get both, but usually get a little bit more of this because you might not get that complete one very soon. You might get more of the widening of these alveoli. So if you look at the actual, if you look at a little bit inside the tissues, we see that there is inflammation in the epithelial linings, and the epithelium might slough off. So there is inflammation and there's mucus production. And there's going to be edema here because of the inflammation as at present. And these are the immune cell system trying to combat the virus at hand. So knowing this pathophysiology we have, what sort of signs might you expect? So I've got the Slack channel on here, so I'm just whenever you guys have an idea, what sort of signs could you get? So people said accessory muscle use, dyspnea, wheezing, yes, potentially. Fatigue, yeah. Cyanosis in severe cases, yes. Breathlessness, low sats, crackles and auscultation, brilliant. Shortness of breath, breathing difficulties, definitely. Okay, all right. So what sort of risk factors could there be? So what are the risk factors that might be at present as well? What could be a risk factor? Just have a general thing. What could be something that could put you at risk? So someone gave another sign, which is hyperventilation. Yep. So we've had dyspnea and breathe. Yep. Premature births, immunocompromised, brilliant. Yep. We've got premature. Sit contact. LBW. Sorry. Yep, intrauterine growth restriction, structural abnormalities in the lungs. Potentially winter months, there is some seasonal aspect to this. There is some seasonal aspect to this. For socioeconomic area, that's not something I've come across in my research that could potentially be where I can't say that can be a potential risk factor or not. Allergies, not usually the risk factor that you would associate with this. Although because if you have bronchiolitis, you are more predisposed to having asthma and other allergies in the future as well. Yeah, so the other one that no one's mentioned here was congenital heart disease. So that's another big one to think about, and in neurological conditions that might actually prevent them from breathing properly. So we have a patient here that's come in, and that's one of the twins of Mariam. And we're just going to stick with one of the twins. And the twin's name is Alex, which gave it gender neutral. It doesn't really matter in terms of gender here. So just have a listen to this patient.
I'm not happy with that, are you?
Okay, I'll play it again.
I'm not happy with that, are you?
And one last time.
I'm not happy with that, are you?
So what problems could you see in this patient? Grunting, accessory muscle, yeah, subcostal recessions, brilliant. recession. So yeah, we can see that recession here.
I'm not happy with that, are you?
You see that these are the recessions. Brilliant. Irregular breathing. Yeah. So yeah. Okay, I'll give you regular breathing. Abdominal breathing, brilliant. Okay, we'll move on from there. All right, so yeah, so in general, these are the main points I took out were the chest movements. So there's a labored, the breathing there with abdominal breathing in place. You get the chest recessions in the subcostal region, and then you also see a hyperinflated chest, and that's coming from the pathophysiology. When we remember the fact that our in our lungs, when we go back, we can see there is this widening of these alveoli, and that's what's leading
I'm not happy with that, are you?
the lungs being larger than normally. Let's now percuss and auscultate this patient. So we'll start off with auscultating the patient. Hopefully you could all hear that. And on percussing this patient, we get this hyperresonant sound as well. Okay, so what have we learned so far about this patient? So give me from, you saw this patient, you came into your clinic and you've auscultated, you've percussed, you inspected, and this is, you're trying to summarize your findings to me. What would you tell me? Okay, so this, in the auscultation, this is supposed to be crepitations. So inspiratory, expiratory crepitations, not wheeze. So there's bilateral crepitations. Yeah, bilateral crackles, yeah. Yeah, so just give me an overall summary. So you've seen this patient and you've done the thing. You've said you've got the bilateral crackles and you've said there's hyperpresent. If you were to give a nice succinct summary of this patient, what would you tell me as the physician you're handing over about this patient? What have you found out? Crepitations and crackles can be used interchangeably. I think it depends on whether you're in America or Britain, but you can use those interchangeably. Okay, so basically what I was expecting someone to just say was essentially give me a summary. So we have a 1-year-old patient with XYZ findings. That's the sort of summary I was sort of looking out for. But anyways, we'll move on. So we have a child here who is, if in terms of the NICE guidelines, who is less than 2 years old and maybe have come in with 1 to 3 days of sort of coryzal symptoms, so sort of flu-like symptoms essentially. And the mainstay is if we're going to suspect bronchiolitis if they have a cough, they have the tachypneic, so that means they're breathing really, really quickly, and they have a wheeze or a inspiratory crackle you hear. They might also have a fever. Apnea, you'd be worried about if they have apnea. So if we go to the next slide here, this is when we start getting really, really worried. If they start in apnea, we see marked chest restrictions and grunting. The respiratory rate is over 70 breaths per minute. That will ring alarm bells for most diseases. Like if you have a child that's having that sort of respiratory rate, your alarm bells are ringing. And central cyanosis, if the oxygen stats is less than 92%, we're worried. And if a physician has said this child looks seriously unwell, you can somehow, when you're looking at the patient, you'll be able to tell this is a seriously unwell patient. But this patient comes in and these symptoms might be a little bit generic in some sense. So, but what else could it be? What other diagnoses could you be thinking of? Apart from bronchiolitis, what other things could you be thinking about for this patient that we might want to also look at? Pneumonia, good. COVID, potentially. Croup, potentially, but unlikely. Very unlikely to be croup. Pulmonary edema, potentially. CF, good. Yes, yes. Think about any sort of chronic pulmonary diseases. Pulmonary congestion of some sort, yeah. Epiglottitis, potentially, but it's very unlikely in this sort of presentation you'd see epiglottitis. Heart failure, good. Yes, cardiac sort of, well, I wouldn't, yeah, heart failure, yeah, cardiac problems, yes, cardiac diseases. So we'll go through what group is, that's our next slide. So we'll go through what group is. Okay, so you've got a good list of other differential and alternative diagnosis. So what would favor, yeah, okay, so someone mentioned viral induced wheeze now, but yeah, so what would favor more likely for it to be pneumonia? If someone has a really high fever, I'm talking 39 degrees Celsius, those sort of fevers, then we're more worried about pneumonia, especially bacterial pneumonia. And if it's a persistent focal crackle, so it's in one place, it's more likely to be pneumonia than it is to be bronchitis. It could also be a viral induced wheeze or an early onset asthma, but usually you just get the wheeze without the crackles. Okay, and you might get episodic wheeze as well. And there is usually a family history of atopy. So what does atopy mean? So they have family history of sort of allergic disease, so they have eczema, asthma, or rhinitis. So there's sort of family history of those recurrent themes. Then, as someone has rightly mentioned, chronic pulmonary disease like cystic fibrosis, some level of cardiac disease in this thing, some pain in the oropharyngeal region, or some sort of aspiration. Let's say they've taken something in and they're now choking, and maybe they've cyanosed. So this would be a bit more serious levels of distinguishing between a bronchitis, bronchiolitis, and a foreign body aspiration. It's not something you'd think top differential if it's not something seriously seen. But if it's a serious case of distinguishing between bronchiolitis and foreign body aspiration, it's sometimes hard to distinguish. So knowing the full history, taking that A to E approach, looking at the airway, their breathing, quite important to distinguish if there is something actually blocking their airway. So knowing this is a viral disease, it's caused some inflammation here. What do you think we could do to manage this patient? What can we do? What do you think we can do? Supportive care, brilliant stuff. Admit for observations if it's serious, yes. So, subvisual nerves, no. Okay. Help with feeding, yes. Fluid supportive, good. Okay. There isn't evidence for you to give bronchodilators or inhalers. It's not seen as useful in this situation. They might give it if it's a very serious case or maybe older patient, but actually usually in the general sense of bronchiolitis, you would not be, apart from part of NICE guidelines, they've mentioned, corticosteroids, inhalers are not something you would be giving. But it is supportive care. So for example, giving paracetamol, having oxygen therapy if their sats are less than 92%, having a nasogastric tube if they aren't able to feed themselves properly. They might have a suction or a CPAP machine that's been put in, or a non-invasive ventilatory ventilation. So those are the ways of supportive care we can give. We don't usually give them this sort of management unless we're suspecting like asthma or some other sort of etiology for this disease. But usually it's quite supportive, and that's the best we can do for bronchiolitis. Remember, it's a viral disease, so you can't even use antibiotics. There's nothing else we can do. It's mostly supportive care. But most children do get better from it, so that's a good sign from this. Okay, so we're going to be now talking about Croup. Okay, so people asking, what is Croup? Well, Croup is so if you were to go to NICE guidelines now, it's mentioned that it's not given. I mean, that's the NICE guidelines I've seen, unless that's part of the BTS guidelines, which have changed. But from what we've seen, they can be given in wards, so it can be still given, but it will be given if the respiratory physician thinks it will be useful. So sometimes there's a judgment call. So guidelines and management might not always mix and say, this guideline, this will always be the case. The physician should say, actually, this child does need an inhaler because of X, Y, Z, or they're suspecting there might be something underlying this, not just bronchiolitis, okay? So they might give it. So it depends on the physician, and they will make that call. So it's not something you will make or anything, but it's not currently under NICE guidelines. So hopefully that helped answer that question. So the second part is we're going to talk about Croup. So Croup is known as essentially laryngeal tracheal bronchitis. So essentially inflammation of these key areas, the larynx, the trachea, and the bronchi. Okay, and because although there are parts of the lower respiratory tracts of the trachea and the bronchi, because of the larynx involvement, we call this an upper respiratory tract infection. So the other thing to notice here is that because there is an obstruction up in the upper respiratory tract, there's going to be slightly different presentations for this disease. And the usual cause for this one is parainfluenza virus, which is an RNA virus, but our respiratory syncytial virus can also be a case as well. So if we look at the disease itself, what you can see is once it enters here, and it starts causing inflammation in this upper respiratory tract area, we find it the child finds it difficult to breathe in and get the oxygen that it needs, and that gives a sound called a stridor, because there is a limited in terms of airflow into this upper respiratory tract. There is turbulent airflow, which is causing this what we call a barking cough sound. And you also get this inflammation in the vocal cords, which can cause a hoarse voice or dysphonia. And you also get them because it's an infection, it's come in and it started to infect the area near the trachea, the larynx, and the bronchi. You start getting edema and the mucus hypersecretion as well. So what sort of signs might you see with a patient with Croup? So given the pathophysiology we know, what sort of signs might you be expecting from this? I've already said one of them, so you can mention that one again if you want. Yep, stridor, good. Barking cough, good. So yeah, we've got the seal bark cough. What else might we get? And with the stridor, is it an inspiratory stridor or an expiratory stridor? Yep, hoarseness of voice or dysphonia. Yep, because of the larynx getting involved. Brilliant. Breathlessness. Yeah, we'll give. Yeah, so they have an increased work of breathing. Accessory muscles used. Good. Chest X-ray does show the steeple sign. That's good, but it's not something we would normally look into. We wouldn't usually do a chest X-ray for a patient with laryngotracheal bronchitis. That it's usually a clinical diagnosis, not usually. We wouldn't usually do an X-ray. The only time you do an X-ray for Croup is if you aren't sure if it's Croup or not. That's the only time you do an X-ray. Normally, you do not do an X-ray for Croup. It's a clinical diagnosis. Okay, so now we are going to look at the patient and see how is this patient presenting. Hopefully you can all hear that.
All right, sweetie. You're my big brave boy. All right, darling. Mummy's here. You're such a big brave boy. Are you okay? I'm tired. All right, darling. Oh, baby.
Hopefully you guys heard that. All right. So what problems can you see and hear from this patient? Okay, so it says, isn't expiratory stridor just a wheeze? So as far as I'm aware, there are 3 types of stridor. So there's inspiratory, expiratory, and biphasic stridor. That's how I've learnt it. But I'll have to check for if it's exactly the same or not, because I'm not too sure. Because we've learnt it as if there is an upper respiratory tract obstruction, we call it stridor. If there's low respiratory tract, it's usually an expiratory stridor that we get.
Alright, sweetie. You're my big brave boy.
What are the signs that we're looking for? What can you see about the patient? You can hear, by that fast breathing, pyropathy.
You're such a big brave boy.
Okay, so yeah, when we're looking at the patient itself, the patient looks slightly feverish as well. We have that sort of barking cough and that sort of coryzal symptoms as well. So how do you think we can manage croup? And do you know a scale of rating the severity? So how can we manage this croup? So given we know of what we know about these symptoms, or the way it presents in the pathophysiology, what do we think we're going to try and do to the patient? If no stridor, then can be managed at home, good. Supportive, good. So when we're talking about there is something you need to give this patient. So even if it's managed at home, there is a specific drug we can give this. Do you guys know what that drug might be? Yeah, good. Oral dexamethasone. Only if they can take oral dexamethasone. If we're not able to give oral dexamethasone, how would we also give it? So how else can we give dexamethasone? If, for example, we have a patient is not able to breathe, what other mechanism or what other ways can we give dexamethasone? IV or IV is one way. What's the other way? Or IM. Brilliant. Yeah. So with Yep, IV and IM. Yep. So with Croup, you will never give any antibiotics because if we remember the etiology, going back, it's a viral infection. So antibiotics is not going to be useful in this case. So we do use dexamethasone to help suppress the immune system a little bit. We make sure that they're well hydrated, and if there is any severe complications, then you might be thinking about so nebulized forms of it's not nebulized forms of dexamethasone that's usually given. There's another drug that you can also give in the severe side of Croup. What could that be? So you're right, we have dexamethasone, we've given dexamethasone, it's not helping. There is a nebulized form of a specific drug that we could give. What could it be? Yes. Yep. So we're going to use nebulized form of adrenaline. Brilliant. Brilliant. I've not heard of budesonide. I've heard of adrenaline. So I won't be able to comment on budesonide. The one I've got down is adrenaline. Okay. So in the NICE guideline, so there is two ways of looking at Croup in terms of the way to see how severe or how not severe it is. So there is the NICE guidelines version, and there is also the Wesley Croup severity score. We tend to use the NICE guidelines, of course, because we're in the UK, but this Wesley Croup severity score can also be used by certain physicians, and they might find it easier to work with. But essentially, the same thing stands for all of these, is that seal barking cough. Now, just because a child presents to you with only seal barking cough does not mean that you should not be wary of the child's past medical history. You need to be wary. Are they immunocompromised? Do they have any congenital defects that could make this condition even worse for them? So do not take the seal barking cough this mild, send them home. Look at it in context. Is there any other severe illness that this child has alongside this group that could make this actually a lot worse? And actually, you might need to give them, you need to step up their management. So moderate is when we have that stridor and that sternal recession at rest. When it's severe, we get that, we get everything we've got in moderate, but we also get that agitation and lethargy. That means they're tiring now, and they aren't able to breathe properly. It's getting worse and worse. And if they're impeding sort of a respiratory failure, then we have asynchronous chest movement, fatigue, palacyanosis. So these are, we're getting worried. Their airways are now compromised. We need to get in straight. They might potentially need to even go to ICU at this point. So this is a severity score usually used more in the US. However, there have been some instances where they have been used in the UK by some physicians. So I'm just making you aware of this scale. So there is different clinical features that are apparent. So we look at their level of consciousness. We look at, are they cyanosed? Is there any stridor? Looking at the air entry, and are there any retractions? So looking at this and given the score, we can figure out what sort of treatment we should give them. Okay, so in the sort of worst case scenario, we're giving them ICU, getting them to ICU, but in the least sort of severe, in the least cases, usually, and in most majority of a lot of Croup symptoms, they can be sent home and be treated with support, giving them, paracetamol, fluids, and things like that. Now, it's mentioned missed here. However, the evidence at this moment in time, according to NICE guidelines, with systematic reviews, have not shown that much of an increase in clinical. There's no clinical efficacy to support human treatment. Some clinicians may say it might help, but there isn't any evidence to back that statement up. So the final case we have before we have our brilliant guest speaker is going to be on this patient. This patient getting older, so we're going to be looking at sort of COVID-19 symptoms. So what can we see from this patient here? So I tried my best to illustrate it. What can we see from this patient here? What do we potentially see from this patient? Lack of taste, smell, and new cough. Good. And yep, good. Technical term anosmia, yep. And cough, persistent cough. All right. So what things can we see? Well, we can see this patient might potentially be feverish. We can see there's got some coughing, and we have that sort of loss of smell or taste. So we're thinking sort of that sort of COVID-19 sort of symptoms, and that's the sort of symptoms they've put in place for even children. But when do we start worrying about these children? When does this symptoms get a lot worse, and this idea of Kawasaki disease started to present, say, oh, could COVID-19 create these Kawasaki disease present? The real etiology of Kawasaki disease isn't fully understood or known, because it can be due to infection. It can also be due to an autoimmune response, but the reality is it's not easy to tell why exactly someone is getting these sort of Kawasaki disease symptoms. It may or may not be related, but someone with COVID-19 may then present with Kawasaki disease. So looking at these pictures here, these are the sort of cardinal signs of Kawasaki disease. However, I will need to mention that under NICE guideline review, because there have been a lot of patients with incomplete Kawasaki disease under the age of 1, they have tried to move away from using this and try to say that this isn't the best and be all and end all way of saying the person definitely has Kawasaki diseases, because someone might have Kawasaki disease but not have all of these symptoms. So let's look at what the symptoms are. So what can we see here? What does this patient have here? This patient here, what is this image on the top left-hand corner? What can we see? What's wrong with their eyes? If you were to describe it in the medical term, what would it be? Conjunctivitis, but what is it? One eye, two eyes? If both eyes, what do we say that is? You're right. So it's conjunctivitis, but you have two eyes. It's not one-sided conjunctivitis. Yeah, bilateral conjunctivitis. Yeah, good. And then what do we see here? What's this tongue called? Yeah, so it's a strawberry tongue, not glossitis. Glossitis, you'd get a, a couple even beefier tongue. So this is a typical presentation of a strawberry tongue specifically. All right, so what do we see here in terms of this presentation of the feet? Yep, desquamation. Yes, yeah, there is a lag. There is a 30-second lag, unfortunately, between YouTube and Zoom. So apologies that it does take a time before I can see what you say and what I say. Apologies for that. Okay, and what can we see for this patient here? What sort of rash do we call this? Polymorphous, yeah. So it's a polymorphous rat, not maculopapular widespread rash. Yeah, you might sometimes get that, but it's mostly called polymorphous rash. So that's the correct answer. So polymorphous because it's not clearly demarcated, and usually actually it's in the truncal region here, and they call it exanthema. So an exanthema is basically a reaction to sort of an infection, so that when you start to get in the skin, they call that polymorphous exanthema. And so this is a one-sided, so this patient only has it on one side. And what is this? You can see. Yep, cervical lymphadenopathy. Okay, yeah, it's a unilateral cervical lymphadenopathy, and they also have fevers of more than 5 days. Okay, so what has Alex developed is developed Kawasaki disease, and if we look at what Kawasaki disease, what happens is essentially there is an inflammation in the medium-sized blood vessels. So this includes the coronary arteries. And the problem becomes is it can manifest itself in different ways. So the inflammation can do a few things. The inflammation, due to the fact that there's weakening of these walls, can cause a ballooning effect. So you have aneurysms coming out from these coronary arteries, and these could burst, and you can start getting bleeding, and then you can get the MI that way. The other thing that can happen is because there is this inflammation, fibrins are depositing, but fibrin is getting deposited again and again and again. And what happens is the coronary arteries getting blocked, but actually they end up having a heart attack quite young. So it's quite important to see if are they having any aneurysms, or could they potentially get a blocked heart? And that's one of the reasons we're worried about Kawasaki disease. So the way to treat Kawasaki disease currently is with aspirin and IV immunoglobulins, and within sort of the 10-day period. Now, what is the problem with aspirin? Why do we usually worry about giving aspirin to kids? What syndrome are we worried about? What syndrome are we worried about with giving aspirin? Rice syndrome, yeah, brilliant. Yeah, and I was looking at NICE guidelines, and they said other potential treatments are available potentially, such as infliximab and etanercept. which are potentially given, but that's not something a junior doctor would give. That's something a pediatric registrar or a consultant would think about giving. Okay, so that's all from me today. We have, and I finished just in the nick of time, because we have a guest speaker coming in 2 minutes. If you can, please, guys, fill in the survey, scan it. Hopefully, you get some. You get your prize. Sorry, your certificate after this. I'm just going to make sure that guest speaker's on. Yeah. Okay. So she's here now, so that's brilliant. I'll just leave my own thing in just so he takes time just to quickly scan and fill in the forms. The form should be put up onto Slack as well.
Hi, Insa, are you ready for me?
Yes, yes. Thank you so much for coming along. Okay, yeah, I'm just gonna stop sharing mine. You should be able to share your screen.
Okay, just before we start, can I make sure I'm on the right Slack feed?
Yeah, it should say virtual elective gynae obs and sprog discussion.
Okay, perfect, thank you.
So I'll turn off my video now. All right, thank you.
Okay. And then I will just share my screen, just make sure you can.
Yeah, I've turned my thing off, so you should be able to share your screen now. Yeah.
Okay, can you see that?
Yeah.
Brilliant. Okay, so hi everyone. My name's Emma. I'm one of the, I'm GP. I work in Birmingham. And also work at the Queen Elizabeth Hospital in their emergency department. So thanks to INSA for inviting me to speak today. I have been given the topic of paediatric asthma to speak about, and I'm going to present it from a primary care perspective. So I'm going to present some common cases. I'm going to spend about 15 minutes on each one. The aim is to try and develop a framework for approaching asthma in younger children in case one, then sort of in older children as well. I'm not going to cover BTS guidelines and NICE guidelines in sort of extensive detail. They're there to read in your own time, but obviously everything will be based on them. I think you would die of boredom if you went through everything in one go. So first of all, I'm going to present the case as if it was coming into GP. Then I will give you the details, give you some time to have a think, and then I will start asking you some questions about it. So please send me questions on the feed. The presentation will rely on you sort of getting involved, and I'm looking forward to seeing what ideas you come up with. Okay, so case one. This is a 2-year-old girl who came into surgery with her mum. Mum comes in and says, "Doctor, I'm really worried about my daughter. She's had a cough now for 8 weeks. We've had multiple courses of antibiotics and it's just not improving. She's waking up in the night, just cannot get through the night without coughing. I'm just really concerned." Okay, so what's your approach to this case? If I give you the details now.
So I might have to warn you, there is a 30-second delay between this and YouTube, so it might take just a little bit while before they
that's
respond.
Fine. I will give it. I can see someone is typing. Okay, so we've got a couple of things first. Someone going straight in with a diagnosis, is it cystic fibrosis? Okay, then also have we established the cause of the cough? Which antibiotics, and could it be asthma? So the way I look at this, try and break it down to how you would normally approach any patient. So first of all, think about the history. So yeah, so you've got questions about the cough. So the cough is not really changed at all. May have started with a bit of a sort of viral infection, but to be honest, the antibiotics didn't make any difference. In terms of antibiotics, she's had some amoxicillin and some clarithromycin. None of it's made a difference. Okay, so try not to jump in straight with a diagnosis. Think about how would you talk to mum? What questions are you going to ask her? Okay, great. So someone said, is there a family history of atopy? Brilliant question when we're thinking about asthma. In this case, there wasn't. Anything else you're going to ask mum? Great question as well, often gets missed. Are there any smokers in the house? And also, are there any pets? No to both in this case as well. Is there anything else you would ask in terms of symptoms? Okay, brilliant. So we've got, did mum smoke while pregnant? Don't think I asked that question, but there's no smokers in the house, so I'm presuming not. Has she had anything like this before? Not really in terms of coughing at night, more just lots of wheeze when she's had chest infections in the past. Any triggers for the cough? Well, we think it started after a chest infection or sort of viral infection, but otherwise it just seems to happen at night mainly. Any siblings? Respiratory red flag, yeah, exactly. Respiratory red flags for acute hospital admission. In this case, no, the patient was fine. And a very Birmingham question, any contact with TB patients? The answer is no. So if we just have a quick look through. So again, we've got travel history. No, she's not been anywhere. Cough is non-productive. And she is not breathless, and she is not unwell. Okay, so let's move on. Some really good ideas there. Generally, when I'm approaching this, obviously you want to take a thorough history and you're thinking about the symptoms which would come with asthma. So typically things like wheezing, shortness of breath, episodes. We've spoken about triggers for the cough. So in children, this might be when they get overexcited. It could be when they're around certain animals, all sorts of things. The other thing you're then thinking about is their personal history of atopy. Do they have anything like hay fever, sort of eczema or anything like that? We've spoken about family history. You also want to know if they have any other allergies, especially drug allergies, if mum knows that they've got a dust allergy or anything. We've spoken about pets and smokers. It's really important that you do ask about smokers at home because that does put children at higher risk of poor control of their asthma as well. The other things which I'd ask in any kid, sort of 2 years old or younger, just ask about the pregnancy. Someone mentioned about mum smoking during pregnancy, but just ask, is it a normal vaginal delivery at term? Were there any pregnancy complications? Just broad questions like that are enough. Is she up to date with immunizations? Is she hitting her growth sort of milestones and her other milestones? So that's how I'd normally approach the history. Now, I'm just going to go back to the chat because there's one big question we haven't asked. Can anyone think what we've not addressed so far, just looking at the details written for case 1? So you can see someone is typing. We'll give it a moment longer. Just have a think about the last statement on the case. Okay, so I think we're focusing on the birth history there. The main question which you need to ask, which we haven't, what's mum concerned about? Because you're not going to get anywhere until mum's concerns have been addressed. And I can tell you that mum's concerns was not asthma. Her main concern was that her child had a persistent infection and we hadn't given the right antibiotics. So until you've addressed that concern, you're not going to get mum on board in terms of persuading her that it's not an infection and that actually more antibiotics aren't going to be helpful. Okay, so remember with pediatrics, there's always 2 patients in the room. You've got to treat the parent as well. Okay, so what next? You've taken your history, what are you doing next in your, now you've got her in your consultation room? Okay, great. So we've got examination there. Yeah, examination was completely normal. She had a normal chest exam, obs were all fine. Is there anything else you would do while you've got her there? Or are you thinking of doing any investigations or anything? Okay, so we've got one suggestion of doing peak flow for an investigation. I'm going to put it back to you. How would you get a 2-year-old to do a peak flow? It would be really, really difficult. The main thing in children of this age, below 5 years, is you can't do any investigations. So your sort of assessment of this child at this point finishes with your examination. Trying to explain a peak flow to an adult can be hard enough at times. Trying to explain spirometry, we often get really rubbish results in adults and older children just because people find it difficult. Trying to do that if you're under 5 is virtually impossible. Some secondary care places may be able to do it with special equipment, but it's certainly not something you'd be doing routinely in primary care. So that's reflected in the BTS and NICE guidelines for assessing asthma in under 5s. Essentially, clusters of symptoms are the most important thing and much more important than investigations. NICE suggests that once they reach 5 years old, if they've still got symptoms, then you can carry out objective testing. The British Thoracic Society is slightly different in that it doesn't put as much emphasis on investigation as NICE does. You'll see that QOF, or what has become, what is now universal offer in general practice, is more based on NICE. So there is quite a lot of emphasis on testing when they reach an appropriate age, but it's not always as accurate as you might hope it to be. So certainly symptoms are the most important thing, which is why it's so important to take that thorough history from mum in the first place. Right, so let's recap. I think what we've established so far, and I hope you agree, is that this child is probably a high probability of asthma. She's got a persistent nighttime cough, waking her in the night. She's also had some wheeze when she's had when she gets some viral infections. And we know the investigation is inappropriate. So we've got to decide what we're going to do with her now. Can we diagnose this as asthma now? Great, so I'm seeing lots of the right answer. No, we cannot diagnose as asthma just yet. You can only really diagnose asthma in this age group once you've assessed response to treatment. So in this case, I think there's two ways you could go down, and potentially either could be appropriate. And I'll explain why you might do one rather than the other in just a moment. Essentially, you can either start this girl on just a Ventolin inhaler and see how she gets on with it for sort of 4 to 8 weeks. And if she gets a good response, you can try stopping it and see if the symptoms have gone away. And if they have, then you don't really need to do anything else. That's more going down the NICE guidelines, where they're suggesting that if they have intermittent symptoms that tend to be triggered by a viral infection, then you can give them the Ventolin inhaler while they've got the symptoms, and then stop it again once it's resolved. The other option, and I suppose thinking about her having more of a nighttime cough, you might want to start her straight onto a steroid inhaler. Now, the reason that you may want to avoid doing that initially is because if she hasn't got persistent symptoms, actually there is a risk of, or a very small risk of growth delay with inhaled steroids, usually only at a high dose. The low dose would normally not be an issue, but there is always that theoretical risk, and that may not be something that is a risk that mum wants to accept. So I think you'd need to discuss the options with mum, assess the patient individually, and decide which route would be best for them. I think in this case, I actually gave her a Ventolin inhaler and we assessed it. She stopped the inhaler after about 8 weeks. The symptoms came back again, so we switched her onto the steroid inhaler. I think that's as valid a route as going straight to the steroid inhaler, because there is a chance that she potentially could go without treatment if she'd responded just to the salbutamol. So any questions about that? Okay, so we've got a first question to start with, is would you only go for Ventolin or steroid after 8 weeks? So I think I probably didn't explain that quite right. What I mean is when I saw this patient, I started her on treatment same day, but I reviewed her after 8 weeks to see what her response had been. You do need a little bit of time for any physiological changes and to see the benefit from it. So hopefully that explains that a bit better for you. Certainly if you thought the patient had symptoms with a persistent cough then and no signs of infection, then there's no reason to carry on waiting. What's the difference between viral induced wheeze and asthma? Good question, because at this age it is really difficult to distinguish. And actually, even at this point, I still probably wouldn't diagnose this girl with asthma until she was 5 years old. I think you can say she has asthma-like symptoms, and it may well be that she gets viral induced symptoms, which just last a little bit longer than we might expect. A lot of children, though, when they have a viral infection, will get a bit wheezy with it. And most of the time that resolves when the infection resolves, or within a week or so after. There are some children who will go on having a bit of a cough in a similar way to adults can get a post-viral cough for a number of weeks after they've had the infection. The other complication is when children go to nursery and they get multiple infections, one after another, because they're all sharing. So it can feel like they're constantly wheezy because of that. And that may also get misdiagnosed as asthma. So you've got, is 8 weeks the cutoff point? I presume, is that for reviewing? I suppose we do, it can be anything 6 to 8 weeks. Like most things in medicine, it's usually quite arbitrary. But the guidelines for BTS suggest 6 to 8 weeks is a reasonable time for reviewing. Okay, so if there's no more questions, I'm going to move on. So we've talked already, I jumped slightly ahead. My question was, what do we need to tell mum about the steroid inhaler? So I would usually only start on 50 micrograms dose inhaler. Higher dose, we were saying, could potentially cause growth restriction, although it'd have to be quite a high dose. The other thing which is important to tell mum is this is a preventer inhaler. It's not a reliever inhaler. So they have to use it every day in order to see the benefits. And explaining the difference between the inhalers is really important because people often don't understand the importance of the steroid inhalers and they think the blue one is the most important. What else are you going to explain to mum while she's here? What else are you going to give with the inhaler? Okay, so we've got one suggestion, advice pack. Yeah, that's really important. The other thing which I suppose you'd include with an advice pack is a asthma management plan, one of the personalised ones, which we can print off directly from the patient's notes. What else though are you going to use with the inhaler? Yes, we've got 2 suggestions. Spacer. Vitally important when you're giving inhalers to children, and actually everyone should have one no matter how old you are. So we usually give the big volumatic ones. I'll talk about other spacers slightly later in this. Now you've only got a short time to teach mum how to use the inhaler and the spacer because you've got 10-minute consultations. We're probably already through those 10 minutes. Where else can you get helped with in sort of teaching mum how to do inhaler technique? Okay, so some really great suggestions there. The pharmacy is a highly underused resource. Nurses, a lot of places will have, a lot of GP surgeries will have asthma specialist nurses. Unfortunately, ours doesn't, which is a shame, but they are a great resource as well. And someone mentioned YouTube, which was another thing I had on my list, and I tell a lot of patients, especially at the moment when we're doing a lot of telephone calls, YouTube has tons of helpful videos, and often they're from some of the charities. Like Asthma UK, which are great for patients. Just see if there's any other suggestions. Yeah, it's your Asthma UK website. Okay then. So mum comes back and she's got a question. She says, firstly, she's like, my child won't use the spacer. What can I do? So what can you suggest to her to help her sort of persuade her daughter she's going to use the spacer? Okay, so we've got one suggestion, which is incentives, like a sticker chart. That's a really good idea. Just, I think someone else is typing. Yeah, games. Mum showing it's not a bad thing. Yeah, all brilliant ideas. I quite often suggest putting stickers on it, so decorating it so it looks a bit more fun. Getting mum or either an older sibling to demonstrate, because younger children often want to copy their brothers and sisters. In the worst case scenario, you can try and use it when the child is asleep, although ideally you want to encourage them to cooperate. Okay, so mum's final question is, will my child need inhalers forever? What do you say to her? I've just seen one suggestion for use it on a teddy for the spacer, which is a great one. Okay, so in answer to mum's question, we've got not necessarily, she may grow out of it as childhood asthma. Absolutely, loads of kids will grow out of it by 5 years, especially if it's more viral induced wheeze. So there are particular factors which may mean a child is more likely to have asthma into childhood. So if they are older than 2 at the presentation, at first presentation, I should say, then they may be more likely. Girls are often more likely to have asthma into adulthood. And other factors are having a history of atopy yourself, or having a family history of atopy are strong factors. And if you have sort of very often, very frequent episodes of wheeze, which are particularly severe, then it is more likely as well. But for the majority of children, they will grow out of it. Okay, so that is the end of the first case. My learning point from this is that diagnosis of asthma in children under 5 years is based on clinical suspicion, not on investigation. I have got a list at the end of some of the pages you can look at in the guidelines if you want to have a quick dip in and out of them. Right, so moving on to case 2, slightly shorter one. This time we've got a 14-year-old boy who came in with his mum. He wasn't particularly sure he needed to be in, but mum was definitely sure that something was wrong. So he was a keen swimmer, did lots of racing at school and swim club, and mum had noticed that his swimming wasn't as good as normal. He was quite breathless at times. He's a known asthmatic, and mum was concerned that his asthma wasn't well controlled. The child himself said that he was fine and didn't think his swimming was that bad. But then again, what 14-year-old wants to come to the GP surgery? So what's your approach? I'll just put out the details of the case so you can have a think about it. Just remember the system that we had before, same system as any case, any patient coming to you. Start thinking about your history first. Okay, so the first question has come up. Does he have a cough? Any nighttime symptoms? Is it exercise induced? So no, he does not have a cough and he sleeps well through the night. He's only getting his symptoms when he's swimming at the moment. Just see if there's any other questions that come up. Does he get asthma symptoms with his activities of daily living? No, he's fine doing everything else. It's just his swimming. What medication is he prescribed? So he currently takes Clenil 100 micrograms, 2 puffs twice a day. And mum says he is taking it. And he does use a spacer, but usually not at school. We've got another comment saying, get the boy involved in the consultation and maybe ask mum to leave because he might be worried and doesn't want to tell his mum. That is definitely important. In this case, he was just, you know, he would rather have been in the pool. So, but he was happy to discuss changing his medication. Have they noticed he's wheezing more than normal? So he's not wheezing and he is taking his inhalers. Okay, so lots of good questions there. So the other questions you might want to ask just with someone who is older as well and has a known diagnosis. Has he had any recent infections? And has he had any exacerbations recently? Has he ever been hospitalized for his asthma as well? Just so you get an idea of what his asthma is normally like. The rest of it in terms of diagnosis, like family history and all of that, we're not quite so interested in this case because we know this kid's got asthma. But otherwise, there's been no changes at home. He's got no new pets, he's doing well in school, there's no smokers at home, and he's up to date with all his IMS and had his flu jab at school this year. So, oh, I'll go back, so just give me the answer. Do you know of any quick ways to assess asthma control in people who are coming for monitoring? So we've got a couple of people typing, just see if there's any answers coming from that one. Okay, so quick ways for assessing his breathing. We've got some suggestions, asking what his breathing is like on a normal day. Does he have a journal? And peak flows. Okay, so all good suggestions. There is a particular set of questions that you can ask though. So you may have come across the RCP 3 questions for asthma. And they are screening questions where you can, if a patient comes in and you just want to have a quick chat about their asthma, ask them these questions and you'll get an idea of what their asthma is like. If they say no to all of them, then you know that asthma is well controlled. I usually pair these up with asking about how often they're using their Ventolin, because if they're not using their Ventolin more than 3 times a week and they're not getting any of these symptoms, then you can be fairly sure their asthma's okay. So let's move on. What are you doing next? So we've got a suggestion for doing peak flow. So yeah, we did his peak flow and his peak flow was normal. Are there his examination was also normal. Any other investigations you would do at the moment? Okay, so we've got suggestions for increasing the dose. So yeah, just thinking about investigations more, we've done his peak flow. One thing you can consider, and someone has suggested, is doing a peak flow diary. It may not be particularly helpful because his symptoms are more exercise related, and you tend to do a peak flow only twice a day with these diaries. And with his clinical history, we're fairly certain that his asthma isn't well controlled. There are a certain proportion of people who have exercise-induced asthma, but in the majority of people, it tends to reflect the fact that asthma is just not controlled. We've had a chat about we've had a suggestion about changing his medication. Out of the 3 options here, what do you think would be the best option for him? Is it either we can increase his steroid dose, or we can add a montelukast, or we can switch into Foster? Oh, I can see we've had one suggestion of doing spirometry as well. You could do spirometry potentially, but I'm not sure how much you would benefit from it in this situation. Especially at the moment, we're not doing spirometry because it's an aerosol generating procedure and the patient does have to be in the room with you for quite a long time. If he wasn't improving with your medication changes, then spirometry is definitely something I would suggest. So any suggestions for what to do with his treatments? Okay, so we've got some suggestions. Depends on age as to which management option. Yep, it definitely does. Maybe change to a combined inhaler. Okay, so we've got one option for Foster. Okay, we've got 2 votes for Foster. 3 for Foster. Anyone else want to try montelukast or increasing the steroid dose? So you've got 1 vote for montelukast. Okay, fine. So in this case, if we talk about these steroids first, in this case, you wouldn't increase the steroid dose as your first option, because like we were saying before, there's the risk of stunted growth. So that's a later option in the algorithm. In terms of montelukast and Foster, either is the right answer. Once you either would add montelukast to their current inhaled steroid, or you would switch them to Foster. So that's essentially the same as because Foster is a long-acting beta agonist with an inhaled corticosteroid. You would never use a long-acting on its own. It has to be with a steroid. But the reason that we'd switch to the combined one is because it's often more, it's better tolerated and people remember to use it rather than having 2 separate inhalers. So for this case, you could either do montelukast with the steroid inhaler or you could switch to Foster. I actually chose to switch to Foster, partly because Mum said he tried montelukast as a child and hadn't found it particularly effective. Montelukast is actually really helpful for a certain subset of asthma where they tend to have quite a lot of allergic symptoms, and they can have a really good response to it. So we tried Foster. Like I say, it's combined ones, so it's just 1 inhaler to think about. With adolescents, you do have to think about compliance. So it's important to do silly things like warn the patient that it's pink, because some boys don't want a pink inhaler. So that's going to change their management if they're just not going to be compliant with using that at school. You need to make sure that they're involved. And I think someone stated that earlier, get the child involved in the consultation. That is really important. So one of the other things, just before I go on, that's the BTS advice. So someone was saying about age. So in children 5 or older, you either add the LABA or a leukotriene receptor antagonist even. Yeah, and that's just recapping what we've spoken about. So the other thing that you need to discuss in this case is a spacer. So Mum said he's using his spacer at home, but not at school. One of the reasons for that in a lot of people is because the volumatic spacers are really big. So you can give them an aero chamber instead. And I actually give most of my patients an aero chamber now, adults and children, because it fits in your handbag a lot easier. It's easy to take to school and work, and people are much more likely to use it. So they come back after they've 6 weeks, and the kid says, my breathing's better, can I stop my inhaler? What's your answer to this? So we've got a couple of answers coming through. Okay, 2 different approaches. We've got a no and we've got a yes, but we're going to have to monitor you to see what else comes through. Okay, and then we've got no, the inhalers prevent you from developing symptoms. Okay, so yeah, my answer is no, he shouldn't stop his inhaler. It's really common for people to think, that's it now, I've had my treatment, I can finish it. People don't like taking medications, including inhalers. So it's important, like we were saying before, that people know the difference between the different inhalers, and that if they need to take something to prevent their asthma, even when their asthma is good, and stressing that part, even when it's good, is the most important part of management or in discussing inhalers. Certainly, it doesn't mean he has to be on Foster forever. He may well be able to step back down. But I think at this point, if he was going to be on, he's been on Foster for a little while now. And I don't think we had any decisions to bring him down anytime soon because he was so well controlled with it. But certainly you'd have an asthma review every year. And you'd go in more detail in the questions about how the asthma was affecting your life and when you got symptoms, what you were doing, which gave you symptoms, and then based on that, you may reduce it in future. Okay. So my final learning points from this case, you can use your RCP3 questions to screen for poorly controlled asthma. It's a really quick and effective way to do it. And make sure you check compliance in adolescents especially. Okay, there's a whole section of adolescent asthma in the VTS guidelines. So just check there's no further questions or anything. So the final take-home messages, just copied and pasted them from before, so you've got them clearly. If anyone has any questions, I'm happy to take them if there's any time. If not, I will make sure the next person can get straight on. I think I've run a little bit over, sorry. Finally, there is some suggested reading. I've just picked out because the guidelines are really long. These are bits I've just picked out which might be helpful and just explain some of the cases that we've spoken about today. So do have a look through those and you can dip in and out at your leisure. And then those are the references to the guidelines. Finally, thank you very much and thanks for the invite for coming today. It's been a pleasure talking to you and having all of your inputs, made it a lot better. And I hope you enjoy the rest of your sessions. I will stop sharing my screen now.
Oh, thank you very much for coming and actually giving us the talk. I was a bit worried, like, oh, she couldn't come or not today. You know, I was a bit worried, but it was brilliant that you ended up coming and you giving us the time to actually give us this talk. It was brilliant. I loved it. It was quite interactive. I thought, I mean, the others can also maybe vouch for that. I mean, it was brilliant talk.
Well, thank you very much, and I will leave you to it. Have a good evening.
All right,
Thank you
bye-bye.
very much.
Bye.
Hi everyone. I think as a group we just wanted to thank you all for coming, and for those of you who've managed to stick it out for the full 4.5 hours, especially a huge thank you to you. And just push another reminder to please fill out the feedback forms. I've stated on the most recent one that if you could please fill all 5 out by 8 PM tomorrow night, then we can try and get certificates done in the next week, and you should have them all sent out by then. So yeah, there's 5 feedback forms. Please make sure you've managed to get them all if you can.
I honestly hope you've enjoyed this session. Like, it was a big effort from everyone. Each and every one of them did a brilliant job, in my opinion. I thought, like, their talks are amazing. In my opinion, I was just like, wow, this. I felt overwhelmed when I tried to give my talk, but it was really, honestly, the interaction from you guys have made it so much better, because like seeing the interactions, like, oh wow, you people are listening, people are engaging, and that makes us like really happy. Chloe, would you want to say anything?
No, just thank you very much for coming. I hope you found it useful. I think we've learnt a lot teaching it as well. So yeah, thank you very much for your time.
I don't really have much else to add, but it's been really awesome, guys, and I think it's definitely pushed us out of our comfort zone in lots of different ways, and also to be on the sort of other side as well. It's a very different time, COVID era, learning remotely, learning online, but you guys have been really amazing in interacting with us, filling out the polls, asking questions and whatnot. So thank you so much. We'll probably put all the feedback forms, the links for the feedback forms again, all together in the different chats and in the different Slack channels, and also on the SDocs Facebook page, and also our Facebook event, just to remind you. But that's it from me. Don't really have much else to add, other than thank you very much, guys.
Thanks, guys. Bye.
Thank you.